Good morning, Dr. Advani. Yeah, can you start, Dr. Advani?
Okay,
So
so
I
I can
Yeah,
Good morning, colleagues. We are really very happy today to discuss in this session on hematological malignancy, and we welcome Dr. Ranjana Advani. She is our friend for so many years, and she is going to give us a talk on nodular lymphoid Hodgkin lymphoma. And I'm sure all of us know her very well, and she has been the frequent visitor to all the conferences. She is a professor at and the Saul Rosebuck Professor of Lymphoma at Stanford Healthcare, California. Dr. Ranjana, please.
Thank you. Okay, so my task today is to walk you through what the best treatment pathway is for nodular lymphocyte predominant Hodgkin lymphoma. And before I dive into the details, I'd really like to thank Smriti and the rest of the organizers for giving me this opportunity to speak. These are my disclosures. So nodular lymphocyte predominant Hodgkin's is a distinct clinical entity. There's male predominance. It's about 65 to 85% of the cases. It's seen in pediatric and adults with a median age of approximately 35 years. Most patients, 70 to 80%, are asymptomatic and have early stage 1 or 2 disease. It involves mainly the peripheral nodes, and the mediastinum is usually spared. It's often non-bulky. A bone marrow biopsy is indicated only if there are B symptoms or cytopenias. It behaves indolently with late relapses, even 15, 20 years later. And you can see histologic transformation to diffuse large B-cell lymphoma, most commonly to the T-cell-rich subtype. And the incidence of that is anywhere about 7% at 10 years, ranging from 2 to 18% depending on the series. And immunoarchitectural patterns from A to D have been described. Pathologically and genetically, this is different from classic Hodgkin lymphoma. So if you just look at the immunohistochemistry markers, nodular lymphocyte predominant Hodgkin's does not express CD30, CD15, and unlike classic Hodgkin lymphoma, which are almost always positive. Very rarely you can see it, but if you really think of the most common scenarios, there's no CD30, no CD15. And in contrast, there's very strong B-cell marker expression. So you get sheets of CD20 positive cells with bright with PAX5 staining, unlike classic Hodgkin lymphoma, where those are rare. Even at a genetic level, the biology is completely different from both those entities. Now, nodular lymphocyte predominant Hodgkin, and I mentioned it can transform into a T histiocyte-rich like large cell lymphoma. And if you look at the genomic level, there are actually similarities between those two entities. So if you look like nodular lymphocyte predominant, there are some common genomic features between those two, and it's quite different from what you get in classic Hodgkin lymphoma. So there are 6 immunoarchitectural patterns described. A and B are considered normal variants, whereas C, D, E, and F are the variant patterns. And the higher the number, the more aggressive it is. And in fact, the E and F are almost considered like a DLBCL. So the Germans developed a score with a male, low albumin, and one of the variant patterns. And a variant pattern being defined as non-A, non-B, so anywhere D, E, or F. And that predicted for progression-free survival. So what we don't know is whether it correlated with the likelihood of transformation. So if you look at the impact of the variant patterns in nodular lymphocyte predominant, if you see bone marrow involvement, which is very, very rare in this entity, less than 10%, whenever you see it, it's usually associated with a variant pattern. Even in stage 1 or 2 disease, the ILROG pattern, the ILROG study, when they looked at the inferior progression-free survival, if there were a variant pattern or more than 2 sites of disease. And of course, for advanced stage disease, those patients present with more stage 4 disease and splenic involvement. So they really don't present like their clinical presentation is also more aggressive, and it has implications for treatment. So it's important to ask your pathologist to report the variant pattern. So if you look at just the age-specific rates and the subtype by overall survival, if you look at lymphocyte predominant, you can see that there's no bimodal peak like you have in classic Hodgkin lymphoma. And if you look at the relative overall survival, it's almost 90 to 100%, unlike the other histologies in lymphoma. Now, one thing to remember clinically that you can see this pattern of continuous relapse. So in classic Hodgkin lymphoma, once you cross 5 years, we usually tell the patients you're cured. And the chances of the disease coming back are probably less than 2%. That's not the case in nodular LP, where you can see, even look at the British Columbia data, where you look at the matched pair outcome analysis, you can get late relapses. It doesn't impact survival though, because outcomes are very good in this disease. And this is the German data where compared to classic Hodgkin lymphoma, you again don't see any flat line, and you can see late relapses. This is up to 12 years, but you can see relapses even 20, 25 years later. So therapy choices vary from radiotherapy to chemotherapy to then rituximab-based therapy. And it's interesting that the therapy choices actually are different from classic Hodgkin lymphoma. And you approach nodular LP more like a follicular lymphoma. So if you look at the choices in follicular lymphoma and the NCCN guidelines, you have, like, if you have early stage, radiotherapy is preferred. If you have advanced stage and there's no indication for treatment, it's observation. That's pretty much the case even for nodular LP, where if you have stage 1 or 2 disease, if it's non-bulky, radiotherapy is the preferred option. And if you have stage 3 or 4 disease, if you're asymptomatic, observation is also indicated. So there are paradigms which are different. So often we see practitioners making the mistake because they see the word Hodgkin's, and a lot of patients land up getting therapy which is not really warranted. Even at relapse, the therapy differs from classic Hodgkin because it can include observation, it can include radiotherapy, it can even include rituximab because of the universal CD20 expression. And relapse Hodgkin's, you would give salvage and transplant, and that's not necessarily the case for nodular LP. So now going back to stage 1 disease, the choice where this is a big study with mature follow-up, which showed that within radiotherapy, involved field radiotherapy was really with very, very good outcomes, much equivalent to the extended field or combined modality. And you really don't need combined modality because involved field radiotherapy does very well. Now, there's a big temptation to use Rituxan alone because these express CD20. That has been studied. And the only wrong choice in early stage disease is to do Rituxan alone, especially if radiotherapy can be given, because the outcomes, if you look at the progression-free survival, it's only 80% compared to a much higher progression-free survival with involved field radiotherapy of over 90%. This is the ILROG data. So if you compare within early stage 1 and stage 2, well, stage 1 and 2 does very well with radiotherapy. But if you look within stage 1 and 2, if people have more than 2 sites of disease, they tend to do better with combined modality therapy than radiotherapy alone. And then the risk factors for not doing well are this variant pattern I talked to you about. And of course, if you have more than 2 sites of disease to make it stage 2. We also have looked at the patterns of relapse or transformation rate progression. And so if you look at radiotherapy containing regimens, there's almost very rare to get a relapse. And if you get it, it's mainly a distant relapse. It's very rare to get local relapse. In contrast, if you don't use radiotherapy and you just use chemotherapy, you do see local relapses and then you do see some distant relapses as well. But there's no really outcome overall survival difference between transformation or no transformation. And for early stage, the risk of transformation is pretty low. It's only about 3.8% in about 10 years. And the risk depends on variant histology and if you have more than 2 sites of disease. What about the radiotherapy field? So remember, nobody uses extended field anymore. It went down to involved field radiotherapy with very good results. And now it's ISRT, which was involved site radiotherapy. And this is data from the MD Anderson group, which shows that even with involved site radiotherapy, the 5-year progression-free survival in this retrospective analysis was 100% with an overall survival of also 100%, with no difference between the modalities. Now, If you have people with stage 1 disease where the lymph node has been completely resected to make the diagnosis or whatever, observation is a very reasonable choice. And that is extrapolated from the pediatric literature. And you can see that they observed patients post-resection if it was just a single site, and the event-free survival was 77%. But if the patient relapsed post-surgery or hadn't had all the sites resected, they got chemotherapy with idrimycin, vincristine, prednisone, and cytoxan for 3 cycles. And you can see that the event-free survival was, again, 88%. But with this approach, 75% are spared chemotherapy and radiotherapy. And for the ones who are in the pediatric literature, those who are treated with radiotherapy, with this chemotherapy, they can avoid radiotherapy. Active surveillance is also a reasonable option even without resection. This is data from Memorial, which looked at 163 patients, out of which about 2/3 were early stage patients. And you can see that there was no difference in progression-free survival or overall survival. This p-value here is actually in favor of observation. There was absolutely no increased risk of transformation, and patients could be treated very easily when they eventually relapsed. So like a low-grade lymphoma, if you have low volume disease, which is advanced stage or even early stage, which has been resected, surveillance is an option. Now, if you look at advanced stage disease and compare the outcomes with classic Hodgkin lymphoma, with median follow-up 11 years with ABVD-like regimen, you can see that the progression-free survival is in the 60% range, unlike the 80-90% range you see with classic Hodgkin lymphoma. And this is because of the late relapses. So, where ABVD, which has very weak alkylator like DTIC, is very good for Hodgkin's, there's emerging data suggesting that for nodular lymphocyte predominant Hodgkin, you need a better alkylator like cytoxan. So maybe a R-CHOP or RCVP approach is a better approach. There are no randomized trials to suggest that, but cumulatively the data from a lot of retrospective series suggests that. And the risk factors for poor outcomes if you have splenic involvement, bulky disease more than 5 centimeters. So R-CHOP has been tried. This is data from MD Anderson with about 59 patients. About 27 of them had R-CHOP. Half of them had stage 3 or 4 disease, and at a median follow-up of about 7 years, the progression-free survival is 88%, and at 10 years, it goes down to 60%. So even with R-CHOP, you can even get these late relapses. But it's a reasonable choice if you have advanced stage disease or bulky disease. The German Hodgkin study group in their HT18 study included nodular LP with classic Hodgkin. And this gives an opportunity to look at the differences of the clinical features. So as you can see, there's much more stage 4 disease with classic Hodgkin lymphoma. There is very little B symptoms in nodular lymphocyte predominant disease. It almost never has a large mediastinal mass, and it almost never has an elevated ESR. So if you have any of those things, you really need to make sure that you've talked to your pathologist again. And also variant histologies are seen in about half the patients, 60% of the patients with advanced stage disease, where it's much less in patients with early stage disease. So in advanced stage, remember in the German Hodgkin study group, they use Biacop, which is a very alkylator heavy based therapy. So that's why there were no differences in outcome between nodular LP and classic Hodgkin, because you're giving them a very heavy alkylator based therapy. And in the interim PET2 negative, whether you did 4 cycles of escalated Biacop or you did 8 cycles or added Rituxan, it really didn't make a difference. And again, the PET2 positive, the nodular LP did worse than classic Hodgkin lymphoma, and about 60% had the variant histology. Again, there's no impact on overall survival. These patients tend to do very well, even if they have transformed. Now, how do you treat relapse disease? Again, as I said, like a low-grade lymphoma, this can transform to a more aggressive lymphoma. And that's why biopsying it is really important to make sure that you're not missing a transformation. And that can happen in stage 1 or 2, where the risk is really low, about 3.8%. And then in more advanced disease, the risk can go as much to about 14 to 15%, depending on the series. And what we've seen is that if you have stage 3 or 4 disease, or if you have splenic involvement, that is a particular risk factor for transformation. So if you have a patient with stage 3 disease with splenic involvement, You're not going to take a spleen out to prove the point, but I think you can assume that that patient has transformation and not do ABVD. You can treat that patient with R-CHOP. Rituxan has been used as a single agent in relapsed nodular LP because of the universal CD20 expression. And we looked at our data and median follow-up of almost 8 or 9 years. And you can see that the progression-free survival, there's no plateau. But the overall survival is excellent. It's over 90%. So again, it's a very useful drug, but as a single agent, the responses are not very durable. Lots of series have looked at outcomes post-transplant, but you have to be careful when you interpret that data because many of them included patients who had variant histology or we just didn't know at that time. So if you just look at or they included patients with transformation. But if you just look at the series from the EBMT with 60 patients, which actually excluded patients with transformation and had chemosensitive disease, the 5-year overall progression-free survival is 66%, overall survival 87%. Again, quite similar to what you see in relapsed aggressive lymphoma. And in the German study, they compared giving single-agent Rituxan or radiotherapy alone with giving R chemotherapy or transplant at relapse disease. And you can see that all the outcomes were all very similar. So if you're using aggressive, so not all patients require high-dose therapy and transplant. It all depends on what the prior therapy has been. And the overall survival, according to the time of nodular LP recurrence, is important. So if they relapse after 1 year, their outcomes are actually very good. But if they relapse within the first year, which are mainly the patients who have variant histology or have transformed, then the outcomes are not as robust. This is the North American data, where again, if you exclude patients with transformation at first relapse, you can see that transformation beyond the first relapse at 17% at a median at 3 years. There's no difference if you have progression of disease within 2 years or after 2 years. So what is the best treatment pathway? So for early stage, there is excellent outcomes with limited field radiotherapy alone for stage 1A, and that is the therapy of choice, ISRT, the 30 gray. Radiotherapy alone may also be appropriated for selected patients with contiguous stage 2 without risk factors. Combined modality, ABVD-based, warrants consideration. If you have unfavorable features such as variant patterns or stage 2 disease with 2 sites of involvement, and there are no large series with chemotherapy alone. There's no role for Rituxan monotherapy. It's reasonable to consider adding Rituxan to ABVD for early stage, and observation is acceptable for patients with stage 1 who are NED after excision. What about advanced stage? It's really important to have very careful pathology review to rule out large cell transformation. And for the choice of therapy, you can't be dogmatic. So you can use ABVD based on the British Columbia data. So in North America, many centers do that. In Europe, escalated BR-COP is used, and it's very reasonable to consider adding Rituxan. And there's some data to suggest that treating with an alkylator like regimen like R-CHOP may have better outcomes. So what I do is I use R-CHOP if I suspect that there's transformation or suspicious pathology. So if you have splenic disease or stage 3 disease, abdominal involvement, or if there are variant patterns, D, E, and F. For relapse disease, again, rebiopsy is really important to rule out large cell transformation. And in your choice of site of biopsy, it's important you biopsy the bulky site or an intra-abdominal node, sometimes a splenectomy, and not just a simple, easy to access node, because that may give you a discordant histology. For an isolated relapse, radiotherapy alone, if there's no prior radiotherapy, and you can observe it has been completely excised. And if there's a systemic relapse, you can do Rituxan alone if there's not bulky disease. You can do salvage and transplant like you do for large cell transformation, or if you have very symptomatic bulky disease, and again, like a low-grade lymphoma, you can do observation if there's low tumor burden. So that is my last slide, and I am happy to take questions. I will stop sharing my screen. I see one question in the chat from Dr. Sanger.
Yes, ma'am. Dr. Reshma Puranik is here. She is the lead discussant for this talk, ma'am.
Yeah.
Over to Dr. Reshma. Ma'am, please unmute yourself, Dr. Reshma.
Thank you, ma'am, for the excellent discussion. We have a few questions. The first question that I've seen in the chat box is, would we use a regimen that is rituximab RAB, that is RABBD, or is it better to use RCHOP? And if we use RABBD, how do we dose the R and how do we sequence and dose rituximab?
I think I spelt it out in the talk. For early stage 1 and 2, if you have stage 2 disease and it's non-contiguous, so you're not going to use radiotherapy alone, and you're going to use combined modality therapy, it's okay to use RABBD if there's no variant histology. And the R dose is standard, 375 per meter squared, and you give it on the same day as ABBD. And you do ABBD every 2 weeks like you would normally do. If you have stage 3 or 4 disease, we prefer to use RCHOP.
Okay, ma'am. Thank you. Ma'am, in advanced stage disease, any particular subset in which we should be considering to use the intensified BCOP regimen rather than RCHOP? Any particular subset practically in our clinical practice?
No, I think you can use RCHOP for stage 3 or 4 disease.
Okay, ma'am. Ma'am, and in the relapse subset, a few of the patients, even if they relapse, like you have told in your talk, they still have good outcomes even with the standard regimens. So there are few patients that can go on receiving these multiple lines of chemotherapy or maybe some radiation. But the one subset of patients, which one of those should directly go for the high dose chemotherapy and transplant? Like which subset of patients we should consider?
Well, the subset is if you have somebody who has presented at diagnosis with stage 3 or 4 disease, and you've given them RCHOP because they have variant histology, and then they relapse, you have to think of that as relapsed DLBCL, and that's the group I would give salvage and take them to transplant. If, however, somebody with stage 1 or 2 disease who relapses, 8-10 years later, you can watch them, you can do Rituxan alone. So it depends on the clinical presentation.
Yes, ma'am. Thank you. Ma'am, one more question in the chat box. In relapse and refractory cases, is there any role for immunotherapy?
I think you mean the checkpoint inhibitors.
Yes, ma'am. Checkpoint inhibitors. Yes.
I mean, Rituxan is immunotherapy too. So no, in nodular LP, there is no role for the checkpoint inhibitors. Unlike classic Hodgkin lymphoma, where they're very active, in nodular LP, they have no activity.
Okay, ma'am. Okay. So
in DLBCL, they have no activity.
Yes, ma'am. And any role of ofatumab besides rituximab? Any data for that?
Well, there is data from the German Hodgkin study group, but it's no better than using rituximab. So yes, there is data for lots of CD20, any of the CD20 antibodies. There's data, even there are case reports with radioimmunotherapy also. So all of those are active, but I would say that the activity is pretty comparable with rituximab. And since all of us know how to use rituximab pretty well, I don't think there's any deviation required from that.
Okay, ma'am. And one of the last questions is for those patients who go for high dose chemotherapy followed by transplant, any particular choice between RIs, RDHAP, RSHAP, any particular choice?
Use a regimen which you're familiar with.
Okay.
Any of them, they're all equivalent. And when you have these multiple choices, it's best to use get good at using one regimen. Okay. So that's expertise, the more you do the same thing. And so that's what we teach our fellows also, like, you pick whatever you want, they're all pretty equivalent, but get good at doing that again and again and again. I don't think there's advantage of one over the other. They're all platinum based. It depends on the comorbidities of a patient. And if the patient has, renal thing, you're not going to give cisplatin, you're not going to use RDHAP. If the patient has a lot of neuropathy, you're not going to do that. So I think you have to individualize it a bit, but they're all pretty equivalent.
Yes, ma'am. Thank you so much for the excellent discussion. Thank you for answering all our practical queries also.
Sure.
Thank you, Dr. Ranjana Advani. I know you squeezed in your lecture, and I'm really grateful for that. And we look forward to more interactions with you in future, especially in lymphoma series.
Sure.
Thank you.
Thank you. Thanks all. Bye.
Thank you, ma'am.
The next lecture is going to be on how to individualize the treatment of mantle cell lymphoma. And for that, I would like to invite Dr. Prasanna Ganesan. He is the additional professor and head in Department of Medical Oncology from Jitmer, Puducherry. So over to Dr. Prasanna.
Good morning, everyone. Today, I'm going to talk on how to individualize treatment in mantle cell lymphoma. So we will be talking about the current management of mantle cell lymphoma, a brief about the Indian data, whatever is available. And then we will discuss the individual scenarios in this rare disease. As we all know, mantle cell lymphoma is a fairly rare disease. It's about 7% of all non-Hodgkin's lymphomas data on the West. In India, it's about 3 to 5% of all non-Hodgkin's lymphoma, and there is a definite male preponderance. And the median age in the West is about 68 years, and whatever data we have from India, it's about a decade long. Most of these patients present with advanced disease, with a significant proportion having involvement of the bone marrow, and about 15 to 20% have a peripheral blood spill. These symptoms are common. About 1/3 of patients have these symptoms, and the unique feature is the involvement of the gastrointestinal tract. The colonic involvement is seen in about 90% of patients with advanced disease. Central nervous system involvement is rare, less than 5% of patients. Diagnosis in the current day is fairly straightforward because of the extensive use of immunohistochemistry. The morphology itself can be variable, though traditionally it's been described as having small cleaved cells. The IHC is quite characteristic with co-expression of CD5, CD20, CD19, and the hallmark, of course, is the cyclin D1 positivity. And more recently, the recognition that SOX11 is an important marker for mantle cell lymphoma. Further confirmation by FISH demonstrating the 11-14 transmutation or by PCR. Now, based on the cell of origin, we have two types of mantle cell lymphoma. One is the classic type, which presents with lymph node involvement and extranodal involvement, usually of the GI tract, which is a much common variety, and it's usually SOX11 positive. The leukemic type, on the other hand, is slightly rarer, maybe 10 to 15% of the cases. Predominantly leukemic presentation, bone marrow involvement, spleen, very limited lymph node involvement, and classically this is SOX11 negative. Importance being that this second type, the leukemic presentation, has a more indolent course. Both these types can acquire genetic abnormalities. Classic type, usually the MYC, P53 can happen in either, but more common in the leukemic type, and then evolve or present with a more aggressive blastoid or pleomorphic mantle cell lymphoma, which is generally thought of as having a poorer prognosis. There are 5 published studies on mantle cell lymphoma, which I could get from my literature review. Consistently, all of them report a median age of about 57 years. And most of them report a significant proportion having bone marrow involvement. And again, 15 to 20, 30% of them having a peripheral blood involvement. Blastoid presentation is seen about 15% of the patients. The prognosis of mantle cell lymphoma, classically we use something called the MIPI prognostic index, which has got 4 variables: age, ECOG, LDH, and the WBC count. Based on this, a scoring system is assigned, and you divide the mantle cell lymphoma into low risk, intermediate risk, and high risk. And this data actually comes from a slightly older German study, which was published in 2008, of 455 patients of mantle cell lymphoma from the German mantle cell lymphoma study group treated between 1996 and 2004. And based on the older study, the 5-year survival of the 3 groups was 60%, 35%, and 20%. More recent data in 2014 of 958 patients in the same group treated between 2004 and 2010 shows a significant improvement in survival, but still the prognostic categories are relevant. The low risk has a survival of 83%, intermediate risk is 63%, and the high risk is 34%. This is, of course, the advent of the rituximab, which has changed the prognosis in this era. Of course, other indices can also be used. FLIPI, IPI, all of these have been shown to be prognostic for mantle cell lymphoma also, mainly the use of age, LDH, and stage are significant. Again, biological factors like the Ki67, which indicates the aggressiveness of the disease, high serum free light chain ratio, and more recently, the expression of P53 have also been identified as prognostic factors in mantle cell lymphoma. If you look at current trials, the median survival is about 8 to 10 years, which is much better than what we see from the German data about a decade back. Having said that, again, I want to reiterate that prognosis is highly variable in mantle cell lymphoma, and even we very well know that based on the biology itself, 2 separate subtypes are recognized with 2 separate prognosis. With this background, let's move on to specific case scenarios where we need to individualize treatment. The first case that we will be discussing is a 60-year-old male who presents with a lymph node swelling, no B symptoms. He has small nodes in the neck and a few in the axilla, a splenomegaly. The counts are okayish except for the increase in WBC count. The bone marrow biopsy confirms the presence of mantle cell lymphoma. However, the SOX11 is negative and the K67 20% is low. PET-CT is done, which is the recommended staging investigation for mantle cell lymphoma, and shows a limited lymph nodes in cervical axillary region, uptake in the spleen and bone marrow. A subgroup of which can potentially be observed without immediate treatment. So this is one study which tried to look at it. This is data from the Weill Cornell Medical Center. Patients treated in the early part of 2000. They had 97 patients of mantle cell lymphoma. Out of this, 31 were observed without immediate treatment. Immediate treatment means treatment within the first 3 to 6 months of diagnosis. And 66 of them underwent initial early treatment. So those who were so-called observed, among those who were observed, 71% of them were observed for more than 6 months, 45% for more than 1 year, and 10%, that's a very small proportion, 3 of them, would actually be observed for more than 5 years without significant progression of the disease. What it shows is that we can have a small group of patients where you don't need initial immediate treatment and they still have a very good prognosis, but the challenge is to identify this. So, of course, these patients were identified based on clinical parameters. What is the difference between those who had early treatment and those who had observation? Typically, the observation group had earlier stage presentation, and the WHO performance status was 0, showing that most of them came with asymptomatic or minimally symptomatic disease. And the IPI was also on the lower side for these patients. Significantly, the MIPI scores were not different between those who were observed versus those who were given early treatment. What happened to the patients of those who had deferred treatment? Obviously, they had a much better survival. Obviously, they had a much more indolent and much more quieter disease. But the moment they needed treatment, from that point onwards, if you compare them and the early treatment, there was no difference. Once they require treatment, from that point onwards, the prognosis is similar. But till the time they require treatment, they seem to have a better prognosis. Again, the challenge here is to identify those who have early treatment and late treatment. It is, as I mentioned, not very easy. There are some pointers which you can look at. Unfortunately, the classical clinical parameters were unable to clearly pinpoint those who were those who could be observed versus those who require early treatment. The other pointers towards this is the Ki67. Again, this is a data which came out subsequently, and here you can see that those who have got a Ki67 of more than 30% have got only a 5-year survival of 41%. So this is a subgroup which you definitely don't want to recommend observation. We know that SOX11 overexpression defines a more aggressive subtype of mantle cell lymphoma. So if you have a SOX11 positive disease, again, you'd be very careful about recommending observation in that particular subgroup. Again, TP53 multiple studies have shown that independent of MIPI and K67 has got a poorer prognosis, more aggressive disease. So these are yet to be validated in clinical practice. So this is a subgroup where you can individualize your treatment and possibly think of close observation. That is a leukemic presentation, splenomegaly, low K67, SOX11 negative, few enlarged lymph node, and possibly, if you have access to that, P53 expression negative. Moving on to the second scenario, this is a 47-year-old male bank manager, presents with fever and these symptoms, the generalized lymphadenopathy. He has got a kind of low platelets and anemia. Peripheral blood is showing atypical lymphocytes. It's a classical mantle cell lymphoma, K67 on the higher side, 50 to 60%, and extensive disease on the PET scan. This is definite advanced mantle cell lymphoma. We are not going to discuss observation here, definitely requires treatment. It's a young patient. What are the options here? So there are 4 options here. One is BR or R-CHOP. This data comes from the STILL and the BRIGHT trial. This is usually used for patients who are not fit for autologous transplantation because currently autologous transplant in CR1 is considered as standard of care for mantle cell lymphoma. This treatment as such would be considered as non-curative. However, as I said, more recent trials are showing that survival is getting pushed further and further. But traditionally, for a younger patient, we would like to do an autologous transplant, and the before transplant regimen of choice currently is a combination of R-CHOP and RDAP, and in a moment I'll show you why. So we continued with maintenance rituximab as per the data from the LYSA study. However, the role of maintenance rituximab after bendamustine-based induction is questionable. You have a median PFS of 7 years and overall survival extending beyond 10 years. And of course, when you add the DAP to the CHOP, you have a better survival. The third option is R hypercvad alone, because most of this data comes from a single center. Hence, it's not very popular across the world. And I will show you some data that you don't have to really use hypercvad. It's definitely a much more toxic regimen. There was one randomized trial comparing Velcade instead of vincristine in CHOP, that is called the Velcade RCAP, which compared to R-CHOP seemed to improve the PFS without changing in overall survival in mantle cell lymphoma. So between BR and R-CHOP, my current choice, as I think most centers in India would use BR. The reason for that is this data from the Still and Bright studies, both of them clearly showed the PFS is better when we use BR. Not only that, the toxicity is much lesser with BR as compared to R-CHOP, other than the skin rashes, which can be troublesome in a few patients, but most of them tolerate the bendamustine rituximab combination much better than the R-CHOP combination, especially when we are dealing with older people. So this is probably the regimen of choice in any patient with an aggressive mantle cell lymphoma whom you are not considering transplant upfront. The data for rituximab maintenance comes from the LYSA study, where the patient after autologous transplant would randomize between rituximab and observation for 3 years. And here clearly there was a superior EFS as well as overall survival with the addition of rituximab maintenance. This is a controversial area whether you still need to do maintenance rituximab after bendamustine rituximab. This is the maintain trial from Europe, and this trial actually did not show any difference in the PFS whether you use rituximab or not in patients who had responded to bendamustine rituximab. Similarly, there was no difference in the overall survival. Hence, the role of rituximab maintenance after bendamustine rituximab induction is questionable. However, there are people who still use it. There are experts who still recommend it, but currently the data does not support it. This is the data to show the effect of a mixed regimen of R-CHOP, RDAP compared to R-CHOP. This is the European Mantle Cell Lymphoma Network study, and clearly you can see there is an improvement in the time to treatment failure, 9 years versus 3 years, which is quite significant, and also in overall survival at 60% versus 12%. Of course, there's more toxicity with RDAP, but for a young fit patient, that should be a treatment of choice. Still think about or talk about hypercvad. There's only one randomized trial which tried to answer this question, comparing a regimen of R hypercvad to 6 BR as a pre-transplant induction regimen. Unfortunately, after 53 of the 160 planned patients were accrued, almost 1/3 of the patients in the R hypercvad arm had mobilization failure for the autologous transplant. Based on this, trial was called off, and the interim analysis of whatever was recruited did not show any difference between these two regimens. So, based on this and other data from some other retrospective series, it is to be taken that there is no real need to push such a toxic regimen as hypercvad, except some centers where they are extremely comfortable and very used to using this toxic regimen. The third scenario, we just talk about an early stage Hodgkin's lymphoma. Here, an elderly gentleman comes with a lymph node mass, bilateral cervical lymph node, no other sites of disease, biopsy suggestive of mantle cell lymphoma. So we don't have randomized trial in this setting. Obviously, it's a rare presentation of mantle cell lymphoma to come with only stage 1 and stage 2 disease. But we have two important studies here. One is from the Nordic lymphoma group, where 43 patients with stage 1 and 2 mantle cell lymphoma were treated with radiation alone, and a 5-year overall survival of 93%. Another slightly larger study from 13 institutions, which were done as part of the International Lymphoma Radiation Oncology Group. And here again, we have an excellent survival. Whatever you use, there is no difference. And the 10-year freedom from progression may be slightly lower when you use radiation alone, but the overall survival is not different whether you use chemotherapy or chemoradiation. So we can safely say that radiation alone is a reasonable option for an elderly patient who presents with limited stage mantle cell lymphoma. There may be a recurrence, but we can treat at that time with chemotherapy or immunotherapy. Maybe for a younger patient, you may add radiation along with some chemoimmunotherapy, but generally the survival in this group is excellent. The last scenario is a relapsed mantle cell lymphoma. I'm not going to spend a lot of time here just to enumerate the options available for these patients. The current choice of a treatment based on a small series of data is, of course, ibrutinib, which has got the best response rate of 68%. More recent data seems to suggest that a combination of ibrutinib plus venetoclax has a response rate as high as 83%. So if somebody can access venetoclax, this probably would be a better choice than ibrutinib alone. For those who cannot access ibrutinib or venetoclax, what we have at this point of time is bortezomib and lenalidomide, both of whom have got modest activity in mantle cell lymphoma, and in the relapse setting can help prolong the survival for a few months or few years, depending on how the patients respond. Some interesting data on the use of palbociclib, because a cell cycle regulating drug, and as you know that cyclin D1 is activated in mantle cell lymphoma, driving the disease. So there is some data to suggest a combination of ibrutinib plus palbociclib can be quite effective in extensively pre-treated mantle cell lymphoma, but at this point we have only data from the phase 1 trial. Of course, CAR T cells, as in any other cancer, has leukemias or lymphomas shown excellent activity, but this is theoretical for us at this point. Needless to say, for patients who have a long gap between their first-line therapy with BR or R-CHOP, re-challenge with IV chemotherapy is an excellent option. So we have a response rate of 75% with BR in patients who relapse after R-CHOP, and patients who failed after BR may still respond to R-CHOP, but the exact response rates are not very well known. One more option which I have tried for some patients is if you have 3 or 4 years after BR and you relapse, then you can redo the BR, and some of them again get 1 or 2 years out of it. So you can mix and match all these things, and the disease keeps responding, and you can try keeping keep on prolonging the survival as much as possible. For a young patient who not yet had an autologous transplant, salvage followed by transplant is also an excellent. We cannot stop without talking about oral metronomic therapy, an excellent option in patients with relapsed mantle cell lymphoma. The first paper came from Morton Coleman's group. It's called the Pepsi regimen, which is a continuous procarbazine etoposide prednisone cyclophosphamide regimen. Generally okay tolerated. You may have to tweak around the doses a bit to adjust to the tolerance of the patient, but they did demonstrate excellent response rates in mantle cell lymphoma at that point of time. Subsequently, another study where they combined the Pepsi with rituximab and thalidomide also showed an excellent response rate and good progression. So this is not something to be discarded, an excellent option in relapsed mantle cell lymphoma, and quite safe and easy to do for many of them. So these are the curves from the Pepsi regimen, and as you can see, the overall survival data looks quite good, and the PF is also quite reasonable. So when we just want to summarize the individual therapy in mantle cell lymphoma in India, first thing is the indolent disease may be safely observed, and we talked about how to recognize those who may have an indolent disease. For young fit patients, BR or R-CHOP, RDAP followed by autologous transplant with or without R maintenance seems to be the treatment of choice. This would be for majority of the patients who are young. For older people not fit for autologous transplant, only BR or R-CHOP followed by R maintenance. For relapse disease, the preference at this point would be ibrutinib. If you cannot access ibrutinib, then bortezomib or lenalidomide are reasonable options, and not to forget metronomic therapy as a very good option for mantle cell lymphoma. I'll stop with this slide. So an excellent database. These are guidelines. At this point, these are in draft form, but are available for access. So any of the students want to access treatment paradigms for most of the cancers, it's available from National Cancer Grid. Most of what I've talked about is available in this one slide. So you can also utilize this resource for understanding the treatment paradigms, and these have been tailored to what can be done in our country. So with that, I'll stop now, and thank you very much for patient listening.
Thank you, Dr. Prasanth. Now, I would like to invite our lead discussion, Dr. Puneet Jain. He's the consultant hematologist from Mumbai. So over to you, Dr. Puneet.
Yes, good morning, everyone. I think this was an excellent talk, Dr. Prashant. So thank you for this lucid and very informative talk. I have some questions for you for this discussion. Now, how would you, in the initial workup of any mantle cell lymphoma, how would you actually put an endoscopy, a CSF analysis upfront? Would you recommend it for all your patients with mantle cell lymphoma?
Thank you, Dr. Puneet. That's a very good question, because as we know, mantle cell lymphoma has got a very high incidence of GI involvement. So residents often ask whether we should ask for a upper GI endoscopy or a colonoscopy in these patients. But the reality is that we take it that the GI is involved. It doesn't change the management for most patients who've got stage 3 or stage 4 disease. So unless a patient comes with early stage mantle cell lymphoma, which itself is a rarity, and you want to rule out a more advanced stage disease, so in that case, probably you would consider doing a upper GI endoscopy or a colonoscopy in a person with a otherwise stage 1 or 2 disease. In a stage 3 or 4 disease who does not have any GI symptoms, I would not really go and do a colonoscopy or a upper GI scopy. Regarding CSF analysis, I think it's not very common to get CSF involvement in mantle cell lymphoma. It's roughly about 5%. So if somebody has symptomatic, yes, definitely you would want to do a CSF analysis. Otherwise, there are some reports which suggest that a blastoid phenotype of mantle cell lymphoma has got a higher chance of CNS involvement. So if upfront somebody presents with a blastoid morphology, you may consider doing a CSF to rule out a CNS involvement.
Thank you, Dr. Prashant. Second question is on surveillance. How would you probably monitor the MRD in mantle cell lymphoma? I mean, do you even use PET as a surveillance technique for patients who have completed their therapy, and how would you use it as a MRD modality?
I don't use PET scan other than at baseline for staging and probably at end of therapy just to document the remission before they go for a transplant or something like that. I do not use PET scan as a surveillance modality as of now in mantle cell lymphoma. I don't know whether some trials are looking at this specifically as an early marker of relapse and something like that. I think in general, there is no data that a PET surveillance improves outcome. So at this point, I don't do any kind of imaging unless it's guided by symptoms during follow-up. It'll be just clinical follow-up, probably a CBC because it's mantle cell lymphoma.
Thank you. My third question is on, how are you placing rituximab in a situation where there is so much of COVID and in the era of COVID? So how would you make any changes to your maintenance rituximab?
So I think we already during the talk we discussed that the role of maintenance rituximab is not very well defined in those who have already got bendamustine rituximab. So in those patients, definitely I don't want to go and do something of questionable benefit. In all the other patients, maintenance rituximab clearly shows an improvement in overall survival. And I think over the last couple of years, we have kind of understood that you don't want to deny life-saving therapies in cancer patients during this COVID time. So I would rather give the rituximab and take the chance rather than, because mantle cell lymphoma is otherwise can be a deadly disease. So I would go ahead wherever it's indicated. I would go ahead giving the rituximab. I would not give it.
Thank you. If I have 2 more minutes, I can ask one more question. Sachin, is there more time?
Yes, sir. Yes, sir. Please.
Okay, so how would you identify patients who might be resistant to ibrutinib? So if you have supposedly started patients on ibrutinib based therapy, what are the telltale signs? Is there anything that can tell us, or is there any follow-up that we should be doing regularly to know whether there is resistance to ibrutinib in relapsed mantle cell lymphoma?
Let me confess that I have not used a lot of ibrutinib in mantle cell lymphoma context, so I don't have any clinical experience on that count. But from the trials, I think about 1/3 of patients with relapsed mantle cell lymphoma actually do not respond. They have like primary resistance to ibrutinib. Are there any factors which can specifically tell us that this person is going to be resistant? I'm not aware. I don't know whether Dr. Manju or Pause, they're on the call, whether you could ask them, or I don't know the answer.
Yeah. I think one last question. How would you put an allo transplant? Where would you like to put an allo transplant? When would you want to offer it? That's my last question.
Again, I must confess, I have not really done an allo transplant in a mantle cell lymphoma. Probably somebody with a blastoid morphology, maybe who has a tough time getting into a remission. Probably you need to use a couple of salvage therapies to push them into a remission, and that person, you expect them to relapse very fast after an auto. So maybe those kind of people, if you get a remission, maybe allotransplant may be an option to discuss with them if they are otherwise young, fit with a donor. That's my guess. I have not really planned an allotransplant in a mantle cell lymphoma.
Thank you, Dr. Prashant. No more questions from our side.
Can I request Dr. Advani and Dr. Bharat Parikh if they have some questions? They're welcome to ask. Dr. Advani?
Yeah, I think I wanted to ask you, apart, why we are not using ibrutinib as an upfront treatment? And second thing is there any data about acalabrutinib in the mantle cell lymphoma?
So yes, sir. Thank you, sir. The first question, yes, there are currently trials which are trying to place ibrutinib in the first line in combination with chemotherapy and are also as part of some chemotherapy-free regimens. So the results of those trials are not yet out. Probably we're going to get them in the next couple of years. So then we will know whether it's really going to be useful to place the ibrutinib in the front lines. Probably going to come. It's probably going to come in the next 2-3 years. We will know the answer to that. Regarding acalabrutinib, yes, there is data for acalabrutinib also in the relapsed mantle cell lymphoma. At this point, it does seem, without a direct comparison, does seem that they are probably equivalent drugs with some differences in their toxicity profile. So I think both of them are reasonable options at this point of time for relapsed mantle cell lymphoma.
Thank you.
Thank you, everyone. Over to Sachin.
Thank you, Dr. Puneet, and I request you to stay for the panel discussion part as well. That is later on. So thank you. We'll move on to our next session, and for that, I would like to invite our chairperson, Dr. Bharat Parikh. He is the senior consultant medical oncologist from HOC Vedanta Ahmedabad. Dr. Sunil Gupta is a senior medical oncologist from Venkatesh Hospital, Delhi. So I request Dr. Bharat Parikh to invite our next speaker, Dr. Nitin Jain. Over to Dr. Bharat.
Thank you. I thank the organizer for giving the opportunity to us. And today we are having very interesting topic, management of chronic lymphocytic leukemia in 2022. And the speaker is very well known to all of us. He is the authority in CLL. He is Dr. Nitin Jain, Associate Professor, Department of Leukemia, MD Anderson Cancer Center, Houston, Texas. And he is leading many clinical research trials in CLL, particularly the use of, in risk stratified patients, the use of BTK inhibitors with BCL2 inhibitors, venetoclax, and do away without chemotherapy, immunotherapy. He has many data on MRD negativity, and with continued MRD negativity, it is interesting to note whether we can stop those patients on treatment, which is very interesting point in our country, where we clinicians are offering the treatment choice because of the short duration BR versus long duration BTK inhibitors. So it will be followed by question answers by the late discussion, Dr. Hari Menon, very well-known clinician oncologist from Bangalore. And I invite Dr. Nitin Jain to enlighten us with the latest data on CLL management in 2022. Over to Dr. Nitin Jain.
Hello, good morning, everyone. Thank you for the invite. So I'm just going to share my screen here. Give me a second here. Can you see my screen?
Yes, sir.
Okay, perfect. Yeah, so once again, thank you, and thank you, Dr. Manju, for the kind invite to this meeting, and thanks for the kind introduction. So my topic today is talking about CLL in 2022, and in the next 25 minutes or so, I will take you through, the data, and also some specific emphasis on the data from ASH, kind of what was added at the ASH meeting for CLL specifically, and then I look forward to the Q&A session at the end. These are my financial disclosures. So as you all well know, the therapy of CLL has changed dramatically. First major development, about 2 decades ago with chemoimmunotherapy with BR, FCR. And now since 2014, we have BTK inhibitor. The first one was ibrutinib. And now since 2022, I think there are some other expected BTK inhibitors which may get approved. I think the most, zanubrutinib is probably the closest one to be approved. We have a new PI3 kinase inhibitor, umbralisib. And then I also listed CAR T cell therapy, which is not, I'm not sure what the approval pathway right now is, but it will be some time, but still some ongoing trial. And then I listed pirtobrutinib, which is LOXO 305, which is also an emerging drug in the field of CLL. And I will show you some data, which was from the ASH meeting. So overall, the field has moved away from chemoimmunotherapy to target therapy. So let's first talk about the first line CLL. So these are newly diagnosed patients who need treatment for their CLL. They meet IWCL treatment criteria. So historically, we have certainly used chemoimmunotherapy, FCR in the young fit patients, BR and chlorambucil in older adults. And that certainly, still is used, I believe, quite commonly in India from the cost issue and other aspects. But at least in the United States, we have moved away from this strategy. And then in the targeted therapy era, the thought is that FCR could be considered for young fit IGHV mutated non-del17P patients, but practically for all others, we have moved to chemoimmunotherapy. We have moved to targeted therapy. And at least at MD Anderson, actually, we have stopped using FCR. We have a new regimen called IFCG, which we have used, but more recently also we stopped using it just because most of the doctors, my colleagues, myself included, and the patients, they don't want to get chemoimmunotherapy when we have really good options with BTK inhibitors and venetoclax. So really at this time at MD Anderson, we're using chemotherapy for no patients with CLL at all. Now, just as a kind of a background, when you look at the treatment options for CLL, what I just want to highlight is that, as I mentioned, chemotherapy could be used for this very selected group of patients. But again, at most centers in the US have moved away, including our own center. And then we have ibrutinib, we have acalabrutinib, and we have venetoclax approved in the United States in the frontline setting. And these are really the available options in the frontline setting for patients with CLL. And then just one caveat here is that for patients who have deletion 17p or p53 mutation, this 1-year therapy of venetoclax or obinutuzumab is not considered to be appropriate because these patients tend to relapse. So let's now first talk about the young fit patients. So these are patients who you would consider FCR-based therapy. So just kind of some, I guess, historical but important studies. First is a CLL10 study. This is again designed before the ibrutinib, FCR versus BR. This is now published originally in 2016, where they showed that the FCR is superior to BR for progression-free survival. Now, more recently, they did an updated analysis, which again doesn't really show anything new, except that the PFS curves are updated. But again, you can continue to see long-term PFS benefit of FCR versus bendamustine rituximab. And here the FCR, the median PFS, was just about 5 years or so for these patients. Now, obviously we have ibrutinib, and there are several randomized phase 3 studies which have come along. For these young, fit patients with CLL, so FCR obviously establishes the standard of care. So the first trial, which really head-to-head compared and tried to make a point that target therapies are better than FCR, was the ECOG trial, which Tate Schoenfeld presented a couple of years ago. So this is a very nicely done trial. For young patients, they got FCR versus ibrutinib rituximab, and ibrutinib obviously is continued until progression. So you get ibrutinib until progression. FCR is 6 cycles standard FCR. And this is old data set. This is data from now, not from this ASH, the previous ASH meetings, where ibrutinib is better than FCR. So this really trial established, for younger patient FCR, which was the de facto chemoimmunotherapy standard established, ibrutinib is performing better. And what they showed was that the performance of ibrutinib really was striking for unmutated patients, because they were chemotherapy arm was not doing very well. But if you mutated IGHV, both groups were equally balanced, at least for the PFS, making a point that for mutated patients, yes, if you want to use FCR 6 cycle time limited, I think it's appropriate, but for unmutated, you can see a striking difference. Now, at this ASH meeting last month, there was a data presented by Dr. Peter Hillman from UK, which is a large randomized study called FLAIR study. So this is a very similar study to the Alliance study, or ECOG study, ibrutinib rituximab versus FCR. So large number of patients, FCR versus ibrutinib rituximab. So it's kind of the same trial design. The only thing here is they used oral fludarabine and oral cyclophosphamide as opposed to the IV version, which we typically use in the United States. Young patients, 60 median age, which is expected because we are comparing it with FCR. Not a surprise, ibrutinib performing better than FCR, as we saw previously. And again, not a surprise, mutated patients doing same, unmutated patients, you see a benefit. So all this looks very consistent with what we kind of already knew from a couple of years, that FCR versus ibrutinib rituximab performs better for overall and for unmutated patients. But one thing which came out of this ASH abstract was that the number of deaths were similar, but if you look at the causes of deaths in the FCR arm, MDS AML, somewhat expected, but then there were 9 deaths from cardiac-related issues in the ibrutinib arm. And they went further, and then they investigated these sudden cardiac deaths. And then they divided patients who have a prior history of hypertension or some kind of a cardiac disorder, or they were on some medicine, for hypertension or something from a heart perspective. And I would just want to highlight this for you is that there were 107 patients who in the ibrutinib arm who had this kind of a cardiac history, and in 7 of them, they had a sudden cardiac death. So that obviously is a huge number of almost 7% sudden cardiac death in this group of patients. And this sudden cardiac deaths have been seen in other studies, I would say at a much lower incidence, but it's in this study in younger patients, that obviously is a much higher number. They didn't see that among the FCR treated patients. So again, I guess maybe a word of caution about ibrutinib in patients who have prior cardiac history, even if they are young. Median age here was 60s. Now let's talk about older patients. So these are the patients typically above 65 years of age in the practice. So again, what has been the standard here, at least in the United States, is based on this RESONATE-2 study, ibrutinib versus chlorambucil. And the most updated data we have, and now we have at least longer data, but the 5-year data showed 70% PFS at 5 years. So this is a number I might tell patients, or if they ask me in terms of long-term outcomes, that at least this large study, which led to the approval of ibrutinib, 5-year PFS was 70%. Now here, the control arm is chlorambucil. So you can argue that we don't have a perfect control arm. Chlorambucil is not commonly used. And then there comes the Alliance study, which was updated at ASH. So this is the ASH data where older patients were randomized to BR versus ibrutinib rituximab. And they updated the data at ASH. Both the ibrutinib arms are really, really superior compared to BR in terms of PFS. You can see how much improved the PFS is with with ibrutinib arms. And rituximab had no benefit over ibrutinib. So both arms are overlapping. So there is no reason to add rituximab to ibrutinib. The PFS, this long-term PFS now kind of approaching 5-year mark, and no benefit at all. And again, with this longer PFS, most of the benefit is coming for unmutated patients. If you look at the mutated patients, which are these dashed lines, the top one is the ibrutinib and the green one is the BR. They are still pretty close together, but the major difference is among the unmutated patients. So not a surprise, but I think it's good to see long-term data showing continued superiority of ibrutinib-based regimen. Now, there are other BTK inhibitors besides ibrutinib. So we talked about ibrutinib, which hits many other targets besides BTK. BTK is a target right here, but it hits many other kinases. Zanubrutinib slightly less. Acalabrutinib really hits BTK and maybe a few other kinases here. So it's much more selective among the three. And acalabrutinib is also approved in the United States based on this study, which is again a randomized trial comparing acala plus obin versus acala alone versus chlorambucil. And this data was updated at ASCO last year, where both the acala arms were performing better than chlorambucil. So now acalabrutinib is also available in the United States as an approved therapy for patients with CLL because it performed better than chlorambucil. Now, what was new at ASH was for the first time we heard about the zanubrutinib data in a randomized study in the frontline setting. So this was a large study. They had a cohort of patients without deletion 17p who were randomized to Zanu single agent versus BR. So again, a good comparator. And this is just one data slide I want to show you in the interest of time. Zanubrutinib is performing better than BR. So again, not a surprise here. This is what we expect. We know we saw with ibrutinib. This is what we expect with acalabrutinib. And now zanubrutinib is performing the same. And it is expected that based on this data, zanubrutinib will also get approval in the United States for CLL. It is not approved for CLL yet, hopefully sometime this year. So then we will have 3 BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib for patients with CLL. And all are, I guess, in terms of the efficacy, they all look quite good and quite similar so far. Now, one of the other important things that's happening in the field is that these BTK inhibitors are fantastic. But the problem is that they work, you have to give them continuously. Obviously, in the context of India, that will add the cost because you're saying you keep taking it forever. And then they don't lead to CR rates, and MRD negativity is really practically unheard of with single agent BTK inhibitors. And then we and others have been working on therapies that can you do time-limited therapy for these patients, as we were doing with FCR and BR. Why we suddenly moved to lifelong BTK inhibitor therapy, and why can't we just do time-limited therapy, be done with it, and then wait for the disease to come back, and when you can possibly resume the same thing again or do something different, but you don't need to be on continuous lifelong therapy. So in this, the first major development was what is called the CLL14 study, which led to the approval of venetoclax obinutuzumab. Now, this is which has been presented now several times actually. Venetoclax obinutuzumab compared to chlorambucil obinutuzumab. This is the data from last year. I think it was EHA, where when obinutuzumab 74% PFS at 4 years, better than chlorambucil. So at least now in the United States, we have these two major trials which tell us, one trial tells us the RESONATE-2, that ibrutinib is fantastic. Then we have the CLL14 trial, which tells us ven-obin is fantastic. And I try to compare these two trial PFS curves head to head in a way. And they look very similar so far, with the caveat that ven-obin is a 1-year therapy. So you're done with 1 year, as opposed to ibrutinib where you have to take lifelong. And then when you compare these two trials, obviously you want to compare what their baseline characteristics were, what are the other factors. And actually they seem pretty comparable, with the caveat that actually more patients in the ven-obin arm had more comorbidities as opposed to the RESONATE-2 study with ibrutinib. So to me, ven-obin is actually, I'm using that quite commonly in the clinic outside of a clinical trial setting because of being a time-limited approach for patients and seems to be doing very well compared to lifelong BTK inhibitor therapy. Now, one group which doesn't benefit the most is the TP53 group, where if you do this 1 year of therapy with ven-obin, these patients continue to relapse. So that's not the ideal strategy for those patients. So from a clinical perspective, and this is a discussion I routinely have in the clinic or with the patients, we have 3 approved strategies in the frontline setting: ibrutinib, acalabrutinib, which are lifelong BTK inhibitor, and then ven-obinutuzumab, which is a time-limited therapy. But there are pros and cons of these approaches. Certainly with ven-obin, it's time-limited, but then you have to monitor for TLS, you have to do obinutuzumab, which is IV, neutropenia grade 3 or 4 is 50%, And then, as I mentioned, P53 patients do not benefit long-term. So when I discuss these strategies, I would say in my clinic, most of the patients go for ven-obin because they like one-year approach for these patients. But certainly, acalabrutinib and ibrutinib are excellent choices as well. Now, one new data set for a time-limited therapy at ASH was CLL13 trial. So the question always has been in the field of, do we need obinutuzumab? Can't I just use rituximab for my patients with venetoclax? And we know obin is better than rituximab with chlorambucil from a CLL11 trial. But we didn't have a data with venetoclax up until this data, which is the CLL13, where chemotherapy was compared to venetoclax rituximab, to venetoclax obinutuzumab, to venetoclax ibrutinib obinutuzumab, so triplet. So 4 groups, 920 patients, so large study. And just I want to show you the summary slide. They only reported the the MRD data. With chemo, MRD was 52% in the blood. With RVEN, 57%, no better. But when they add the obin-ven, you see a dramatic improvement here of almost 30 percentage point. And then the triplet was kind of the same as the doublet. So really, so far maybe establishing that ven obinutuzumab is really better, and it is certainly better than rituximab venetoclax. So I think obin does add high rates of MRD negativity for these patients. Now, we talked about BTK inhibitor, we talked about BCL2 inhibitor, which is venetoclax CD20 antibody. But then we and others have started to look at the doublets of oral therapy, BTK plus BCL2. And some people are now looking at all triplet together, but it's not really clear if you need triplet or not. So when you talk about this doublet, so we started working on this concept now around 2015 or so. This is combining ibrutinib plus venetoclax for frontline therapy of CLL. So here we give 3 months of ibrutinib, and then we add venetoclax, and then the venetoclax goes on, the doublet goes on for 2 years. And then if you're MRD positive at 2 years, you can get a 3rd year of therapy as well. So in this trial, we enrolled 120 frontline patients and 80 relapsed refractory patients. So at the ASH meeting, we updated the data for the first time for the 120 patients, where you can see their median age was 64 years. These are high-risk patients, high-risk genetic patients. So majority of the patients were unmutated. You can see 1/4 of them had TP53 or deletion 17p. And this was the updated data on an intent-to-treat analysis. In the bone marrow, at 1 year, 52% were MRD negative. At 2 years, were 64% MRD negative. And it's the best response at any time during the study, 72% were MRD negative. So these are the final, I guess, intent-to-treat analysis for these patients. So now, majority of these patients have stopped therapy at 2-year mark, and we are watching them in the off therapy phase to see what happens. And this is their PFS. Our median follow-up is close to 44 months. So this is a somewhat of a mature study, and you can look at the PFS looks really quite well. There are only 2 CLL progressions and 2 Richter's transformation in this 120 patients. And it's upwards of 95% or upwards of 90% here. So that looks quite good at almost 4-year mark with these 2 oral drugs together. And we are not alone. Captivate study, which is a much larger study, international study, also updated the data at the ASH meeting. And this is a much bigger group of patients. And what you can see here is that the PFS for there are different randomized arms, and I won't go into that. But I just want to highlight is that you just look at the PFS curves. They look fantastic with these 2 oral drugs. So our MD Anderson data, which was a single center study, and this multi-center large study, pretty consistent results of very excellent PFS for these patients. And there are triplets going on. So basically you do ven-obin and you pick your BTK inhibitor, ibrutinib or acalabrutinib or zanubrutinib. Multiple groups are looking at it. We are also actually looking at it. I'm not going to go into the data, but so far it's not clear whether the triplet is adding anything to the doublet. And I think we have to wait for the PFS curves to mature to see if the triplet will do any better, because all the regimens are looking great and doublets are looking great as well. So I think based on the MRD, it's difficult to say because all the trials are showing 75% MRD negative rates. Whether that will mature into a better PFS remains to be seen. Now, what's coming for CLL? Frontline. There are many trials which are ongoing right now. The most advanced, I guess, is this trial, which is FCR versus Acala-Ven versus Acala-Ven-G. Again, the goal, as of all if you see here, is to get these doublets and triplets, compare them to get approval. So this is a trial which we are waiting for the results. We'll see when that comes out. But there are some other trials where you can see some of the new trials, the chemotherapy is all gone away. The control arm is actually not chemotherapy. It's either ibrutinib or Ven-G. So I think the field of CLL has evolved where the standard of care has, at least in the United States, has become non-chemotherapy approaches. So in the field of CLL, in the frontline setting, we have BTK inhibitor, we have BCL2 inhibitor approved. Ibrutinib plus Ven should get approved sometime this year. Whether we need triplets, who knows, remains to be seen. And then most of the therapies are being done for 1 year. I think that will be the approval. But we truly don't know if you're using this ibrutinib combination, do you need 1 year or 2 year? That remains to be seen. Now I have only like 3 or 4 minutes left. But I think I will hopefully finish on time. So I just want to briefly touch upon relapse CLL, and I will show you, I think, 3 data sets. First is that this is not a new data set. This is from last year. Because now that we have multiple BTK inhibitors, the question arises, which one is a better or which one is a safer? So this was addressed first in the Elevate study, Elevate RR study, where patients who are relapsed refractory, they were given Acala plus Ven. Oh, Acala versus ibrutinib. Head-to-head trial. Efficacy, same. No difference in the efficacy. But safety, better for Acala as opposed to ibrutinib. So you can see 16% AFib with ibrutinib versus 9% with Acala. Bleeding less, hypertension less. So safer, but equally effective Acala when you compare with ibrutinib. What about zanubrutinib? Zanubrutinib is a similar trial, Zanu versus ibrutinib. Just going to show you one data slide. Less AFib with Zanu compared to ibrutinib. So kind of the same theme. The second generation BTK inhibitors, Acala Zanu, are safer than ibrutinib and appear to be equally effective than ibrutinib. The last data slide I want to show you is pirtobrutinib, which also previous name was Loxo. Okay. Pirtobrutinib, which is Loxo 305. So this data, you remember like a few minutes ago, I showed you the kinome profile of ibrutinib, acalabrutinib, zanubrutinib. They were hitting some other proteins, some other kinases. This drug just hits BTK, nothing else. It's a very, very potent BTK inhibitor. A large study was reported, 261 patients with CLL. All of them, what they reported was had ibrutinib, 40% had venetoclax. So, somewhat of a refractory patient population, 3 prior lines of therapy. And look at their lymph node response. All these patients had prior ibrutinib. Some had failed ibrutinib, some had toxicity to ibrutinib. But you can see a uniform, practically beautiful lymph node response for these patients. And what is also important about this drug is the safety. So they reported safety, combined safety analysis of CLL and NHL patients, 618 patients. And look at the grade 3 or 4 adverse events. Practically nothing. Neutropenia. But besides that, AFib is less than 1%, hypertension to really non-significant. So this drug actually is a very, very safe drug. I have treated a lot of patients on this drug, and really patients have really practically no side effects. So a safe and effective drug for relapsed refractory. And now this drug is moving into the frontline setting and is also going for approval strategy. So this will be actually a very important drug for the field of CLL and for the patients. So my last slide, this is kind of, I just maybe main highlights from ASH 2021. Certainly, zanubrutinib, a new BTK inhibitor, will come in the market for CLL. We should also see this doublet of ibrutinib plus venetoclax coming along for CLL. What we also learned is that UBIN is better in CLL compared to rituximab when you combine with venetoclax. So if all things being equal and UBIN is also available, then yes, UBIN should be the way to go. We don't really talk about this, but the question of 17p53 patients remains intriguing. What is the best therapy for them? In our center, we use BTK inhibitor therapy, but BTK plus VEN is also looking quite promising in some retrospective analysis. LOXO 305, as I mentioned, safety is really excellent and efficacy. We did not hear much from ASH, from CAR-T, and that's why I didn't include the CAR-T slides because they were from the previous ASH. But I think hopefully this year we should hear some updates on CAR-T specifically for CLL. So with this, I would like to conclude and thank you for listening and happy to take questions. Thank you.
Thank you, Dr. Nitin J. Excellent presentation and update, and thank you for updating us with the latest data and with the latest molecule with good safety profile. Over to Dr. Hari Menon. I'm sure there will be lots of questions. Over to Dr. Hari Menon.
Thank you. Thank you. Hello, Nitin, and always nice to hear and always as lucid as ever. I don't see any questions in the chat, but I'll start off the discussion with a few points. Number one is you also mentioned in your talk that is a time for us to really do away with chemoimmunotherapy, compelling evidence, and on the verge of it being discouraged as part of any protocol. And number two, why is still smatterings of studies going on, still looking at chemoimmunotherapy as one of the comparators when we are looking at treatment? Is it just to demonstrate the profound activity of these medications, or is there some scientific basis for that?
Yeah, so I think first of all, nice to see you, Dr. Hari, as always. And I think so. I would say that practically most of the randomized trials which were designed 3-4 years ago, and you're seeing the results now, they were designed at a time when chemotherapy was considered the standard. But moving forward, the new trials which are being designed are all with non-chemotherapy, except the LOXO 305, which I showed you. So they are going to do BR versus LOXO 305 in the frontline CLL. Obviously, that trial is not going to really accrue in US because US, no one is using BR these days. So that trial, I think they're going to run in Europe, where still from cost perspective or national approvals perspective, BR is still considered, an appropriate strategy, as is I'm sure in India. So they're going to run that trial in the US, in the UK, in Europe. Your point is well taken, right? At the end of the day, they want to get the drug approved, and going head to head with ibrutinib or acalabrutinib in the front line, though maybe the most ideal strategy, may delay their approval or maybe a risky endeavor. So I think there's some business decisions they have to make there. But at least in the US, I don't think FDA would allow a frontline study for CLL approval with chlorambucil anymore. BR may still be considered appropriate because, but chlorambucil, I don't think they would allow that at all.
Yeah, thank you. And number two, next is coming to the MRD as a marker for us to determine how long you should continue the medications. Now, setting aside, of course, the IGHV unmutated and also 17p deletion, and when the issue is about continuing therapy and also sustaining therapy over here, are there some studies looking at whether you can, say, for example, at 1 year, look at the MRD negative status. Suppose the patient is on venetoclax, because these are expensive medications, and suppose we are implementing such treatments or we are counseling patients for such treatment, maybe some of them can continue about 1 year. And if you were to achieve that MRD status at the negative status, would there be a scientific basis to say that, okay, instead of the 2 years that is being prescribed right now, whether we can go away at 1 year without taking the medicine?
No, so so in the frontline setting, the approval is for 1 year, when obinutuzumab, and the relapse setting is for 2 years, where ven is continued for 2 years. So in the frontline setting, it's 1 year, and the recommendation is really to stop at 1 year, irrespective of the MRD. And the question becomes in the US, because many investigators, including me, check the MRD at the end of 1 year. And then the question becomes, if you're MRD negative, okay, that's great. Anyways, the therapy was for 1 year, patient became MRD negative, everyone is happy. But if the MRD is positive, then what are you going to do? Should I continue venetoclax longer for those patients, or still I stop at 1 year because the recommendation is for 1 year? So that becomes a question which now will be addressed in a clinical trial called the MAGIC trial, where they will do some randomizations based on that. In the relapse refractory setting, where the venetoclax duration is for 2 years, can you stop therapy at 1 year mark? I think that's a good question. No one is specifically looking at it per se. I would say that I have some patients who have become MRD negative at 1 year mark. And if they're having some issues in terms of tolerability or some neutropenia or whatever, then I'm a bit more comfortable stopping it earlier, because it kind of makes sense intuitive that you're MRD negative, you have achieved a deep remission. But I don't think any study specifically is looking at that in a randomized fashion.
Thank you. And before I ask my next question, there's some question in the chat box, and the one question is, what evaluation would you suggest prior to start of a BTK inhibitor in patients with coronary artery disease?
Yeah, so the standard we do in our is just the echo and the EKG and echo, and just to make sure their AF is fine, and if their hypertension is well controlled on the antihypertensive medicines. I would say that in the United States, because of the availability of acalabrutinib, because of the data I showed you, that acalabrutinib has less side effects than ibrutinib, and this data with certain cardiac deaths with ibrutinib, which has not been shown with acalabrutinib. Myself and most of my colleagues at Anderson and elsewhere have moved away from using ibrutinib. So I'm practically not using ibrutinib. I'm using acalabrutinib for all my patients. Because acalabrutinib still has that risk of hypertension and AFib. So as a standard practice, I do, as I said, do an EKG, echo, make sure the blood pressure is fine. I do try to avoid, I think the second question I can also see in the chat with Dr. Manju about the antiplatelet therapy. Given again availability of venetoclax, which doesn't have that issue of bleeding issue or platelet aspirin antiplatelet issue, and so if a patient is on anticoagulant, if they're on dual antiplatelet, for sure, I'm not using BTK inhibitors, just because I'm worried, even a small risk of bleeding. Why to take when you have an agent like venetoclax, which is time limited and does not lead to bleeding complications? So if they're just on aspirin, it's okay, acalabrutinib is fine. But if they are on Xarelto, some kind of a anticoagulation and Plavix plus aspirin, and they had a recent heart stent or whatnot, then I'm not using, just because we have availability of venetoclax.
So the perceived question which I was also proposed to ask about Richter's transformation in CL. Suppose the patient has not received any, he was on follow-up on CLL and has not, and then has a Richter's transformation. How effective are these BTK inhibitors under the circumstances? And what is the impact of venetoclax in this situation?
Yeah. So, single agent ibrutinib or acalabrutinib probably has limited role in Richter's transformation. There's some data with acala, but they said 40% response rate, but the median PF is like 2 months. So that's just based on the next scan when you did the next scan. So it's not really very effective. There is data with R-CHOP plus VEN. There's data with EPOCH-R plus VEN, which was just published in Blood. Our group is a part of that. We have worked on checkpoint inhibitors. Actually, I did include the slide deck. We had a presentation on atezolizumab, VEN plus obinutuzumab in Richter's transformation at ASH meeting. And we have done previous work with nivolumab in the Richter's transformation field. And then, so I think the goal becomes get the patient in remission of some kind, whether it's if a young patient, do R-CHOP VEN, a non-del 17p R-CHOP VEN. If a 17p patient, we try to do a checkpoint, avoid chemo, do nivo, ibrutinib, or we had the trial with VEN-based atezolizumab. and then get them to transplant. There's also some data with LOXO 305, the pirtobrutinib, which was reported at last year. With single agent LOXO, majority of the patients, there were 17 patients, and actually I have several patients on that trial. They can respond very nicely, and I had a couple of patients who were able to go to an allo transplant as a next step after LOXO. So we're going to have a trial with LOXO plus VEN plus OBIN as a strategy for Richter's in about 3 months at our center. So that will be something, we'll see how that pans out. But yeah, I think it remains a tough disease, tough thing to manage. I mean, I would say none of the strategies I'm telling you lead to long-lasting remissions unless you can get the patient to a transplant.
Right. There's another question by Dr. Prasad, and his question is, can BTK inhibitors do what TKIs are doing in CML? And are we moving that way?
I mean, yes and no. I mean, I think CML story obviously much different. You have one genetic abnormality, it works beautiful, patients are living forever. I mean, normal life expectancy.
Yes.
But I think BTK, to some extent, yes. But as you saw if you compare the PFS curves for CML patients versus CLL, CLL patients still are relapsing. And now, what's happening is there are multiple patients who are, because, they started the ibrutinib some years ago. Median PFS with frontline ibrutinib is 7 to 8 years. So they will relapse. Then they will go to venetoclax. And they will relapse in 3-4 years. So I think we'll eventually have a pool of patients who have failed multiple lines of therapy and they're living longer, and then they will need more subsequent therapy. So in some sense, yes, they are doing the same thing as TKI, but CML story is obviously much different.
And intrinsically, the inability of BTKs to induce MRD negative status is.
Yeah, that's a perfect.
That's
argument.
fundamental for
Yeah.
So I've asked this question several times. We know that obinutuzumab is a lot more potent than rituximab, but essentially the mechanism of action is the same. Then why this great difference where rituximab has really not added too much to the armamentarium except when, of course, using it with venetoclax but not so much when using it in combination with the BTK.
Yeah. So don't know for sure. Some simple observation is that when you use obinutuzumab, in terms of per milligram dose of obinutuzumab is much higher than what you use with rituximab in terms of milligram to milligram. So the amount of drug technically, the drug you're giving is much higher. Second is this concept about ADCCs and how these drugs interact in terms of NK cell function, like how ibrutinib or acalabrutinib, these days drugs interact in terms of NK cell function and how much NK cell function for ADCC you need with rituximab versus obinutuzumab. So I think the preclinical data, initially suggested that combining rituximab with ibrutinib will be counterproductive, that there will be negative impact. In fact, there were studies which suggested that caution of using ibrutinib with rituximab. At the end of the day, we saw that there was no benefit. It's not that it was a negative study, there was no benefit. So I don't know, I guess whether it's just the dose of what obinutuzumab dose is given as opposed to rituximab. But at least the data we have with venetoclax seems to suggest that that's better, and there is no interaction as compared to BTK inhibitor where these NK cell interactions, venetoclax has really no effect on the NK cells.
Manju has another question, and that is on mutated IGHP with no other high-risk cytogenetics. Would you suggest BR in older individuals, given fixed duration and no overall survival difference, or would venetoclax or obinutuzumab would still be a preferred option?
So, again, I think at our center, yes, obinutuzumab is the preferred option because we have moved away from BR. But because Ven/Obin, in all fairness, is also a fixed duration option, right? So we're not talking about lifelong BTK inhibitor. And so the concern with using, again, chemotherapy with the prolonged myelosuppression for some patients, infections, whether it's a bad option, no. I mean, certainly if the cost is a consideration and Ven/Obin is certainly more expensive than BR, I think it's perfectly fine to use. I think in our setting, like in our setting where I am, just because Venobin is so easily available, and it's also a time-limited approach. I go for Venobin as opposed to BR, but yeah, certainly using BR is not inappropriate at all.
So just wanted to understand, we encounter quite a bit of toxicity when we use venetoclax in AML patients, and of course they're different. How is it to the same degree? What are the toxicities when we are combining venetoclax with ibrutinib as against using obinutuzumab?
Yeah, so obviously AML story is different. More myelosuppression, especially if you do Ven-Aza and you do continuous Ven for 28 days. I think that will lead to myelosuppression. More prolonged myelosuppression. With ven-obinutuzumab, actually, it's a pretty straightforward regimen. The main thing I see is neutropenia, 50% grade 3 or 4 neutropenia, which is something which you can check the counts, hold the drug, give Neupogen or GCSF to say. The TLS monitoring is more logistic issue. They have to come get the labs, but no one really gets TLS as long as you follow the parameters, hydrate them, give them the allopurinol. It's just they have to come frequently for the labs and monitoring. And after they finish the initial couple of months, it's pretty straightforward. I mean, no one gets any ibrutinib kind of side effects to say, and and the only thing you have to watch after that is just for neutropenia. When you add ibrutinib or ibrutinib plus venetoclax, which we did quite a bit, certainly then you run into the issue. Same neutropenia is still an issue, 50% neutropenia, but then you also then have to deal with ibrutinib side effects, some of these arthralgias and AFib and things like that. But overall, I think prolonged myelosuppression, if you're worried about, except I think one patient I had where he had prolonged myelosuppression, no one really had such a prolonged myelosuppression in my experience with ven-obinutuzumab.
So I don't see any further questions, and I think we have crossed our time by 4 minutes, I think. Yeah. So from all the organizers and personally from my end, thank you for the lovely talk and the wonderful interaction and answering everything with so much clarity. And thank you, Nitin, for that. Yeah,
thank you very much. It's just before midnight
yes.
Here, and I wish you guys a happy Sunday morning.
Thank you, Dr. Hari. Over to organizers.
Take care. Bye.
Thank you. Thank you. Bye. Take care. Good night.
Good night.
So thank you so much. For the next set of chairpersons, there will be Dr. Malay Nandi, the Director in Department of Medical Oncology from GAP Hospitals, Noida. Dr. S.V.S.S. Prasad, Consultant Medical Oncologist from Apollo Hospitals, Hyderabad. I request the chairpersons to take the next session. Thank you.
Thank you, Sachin. I'm Dr. Prasad, and we'll be having the next talk on multiple myeloma. As we all know, we have traveled a lot with myeloma. It's still being an incurable disease. We still have relapsed refractory myelomas, and that's where we have these second-line drugs like carfilzomib, pomalidomide, Darzalex. Darzalex, as we all know, has certainly made a lot of difference, but still we have, again, a relapsed refractory myeloma at the end of the treatment. And so we are in need of novel agents, and that's what the next speaker is going to talk. And I would request Dr. Malay to introduce Dr. Pankaj.
Good morning, everybody. Dr. Pankaj is going to be talking about how best to incorporate these novel agents in the management of newly diagnosed multiple myeloma. He is the professor and head of department at clinical hematology and medical oncology at the PGI Chandigarh. Dr. Malhotra, please.
I thanks the organizing committee of the ISMPO to associate me with this important meeting. The topic which is given to me is how best to incorporate novel agents in the management of newly diagnosed multiple myeloma. Now let's start with few facts about multiple myeloma. Multiple myeloma constitutes 10% of hematological malignancies. The median age is 65 years. That means it happens mostly in the elderly age group. Though in the Indian setting, we are more used to see patients in the younger population 40 years or 45, 50 years, but the median age remains high. It's still an incurable malignancy. And even if you diagnosed a patient of multiple myeloma, you have 10 patients of multiple myeloma, all will behave differently. That means they are multiple myelomas. Current treatment only prolongs the survival, even though we have plenty of medicines and maybe a small percentage can be cured. But the current understanding is that we can only prolong survival. However, the median survival, which was used to be 3 years around 2 decades ago, is now ranging more than 10 years in most patients. This is one paper which is published in Leukemia 2017, which tells about the trends in overall survival and cost of multiple myeloma from 2000 to 2014. And in this graph, you can see that as from 2006 to 7, 8 and 9, 10 and 12, gradually the multiple myeloma patients are living longer. And obviously this is up to 2012, and this graph I'm sure is here at this point. So the goals of treatment of multiple myeloma are: number one, reverse the ongoing or impending organ dysfunction which is going on, mostly which is noted by CRAB, hypercalcemia, renal failure, anemia and bone lesions. Once you give treatment, the idea is to improve the progression-free survival and overall survival of these patients. The therapy which is given should be safe and also maintain the quality of life. And the last is the cost effectiveness of the therapy, as you are not going to cure, so you have to decide your therapy which can give a good quality of life for a prolonged period of time and is cost effective also. Now, the treatment of newly diagnosed multiple myeloma is divided into what is like treatment of acute leukemia. So you have induction therapy, you have consolidation therapy, and you have maintenance therapy. The good thing is, as I said previously, that we have a lot of treatment options these days. And these treatment options can be divided into chemotherapy, corticosteroids, immunomodulatory drugs, proteasome inhibitors, cellular therapy in the form of auto or allogenic hematopoietic cell transplantation, anti-CD38 antibodies, HDAC inhibitors, targeted therapies, antibody drug conjugates, and cellular therapies. And the last is bispecifics. So in chemotherapy, you have the old drugs like melphalan, cyclophosphamide, bendamustine, doxorubicin, cisplatin, vincristine. Corticosteroids, mostly either it is the dexamethasone or prednisolone which is used. IMiDs came into pictures 2 decades ago: thalidomide, then lenalidomide, and now pomalidomide. Proteasome inhibitors followed subsequently to IMiDs. Bortezomib was the first one, then carfilzomib, and oral proteasome inhibitor ixazomib. The anti-CD38 antibodies like daratumumab, isatuximab, and anti-SLAM F7 antibody elotuzumab. HDAC inhibitors like penobinostats, although they are withdrawn from the market now. Targeted therapies specifically for 1114 myeloma or amyloidosis, venetoclax. Antibody drug conjugates, belantamab. Cellular therapies, CAR T-cell therapy. ID-cell is already approved and CAR T-cell is likely to get approved. And the bispecifics, which are right now not approved and they are in the pipeline. So once we have plenty of these medicines, now what are the variables that affect our induction regimen in multiple myeloma? And these you can divide into whether it is disease-related variables, patient-related variables, or miscellaneous. When we talk about disease-related variables, these are whether the patient falls into a standard risk or a high risk, whether the patient has renal failure at the time of diagnosis, extramedullary disease, what is plasma cell leukemia, what is the ISS stage or the revised ISS stage. Coming to the patient-related variables, these are the age of the patient. As the age goes up, the tolerability goes down, and many of the therapies you cannot give at an older age. The transplant eligibility, although all patients are taken up, they are eligible for transplant, but many times because of the age and comorbidities, these patients cannot tolerate high dose chemotherapy, and hence they are transplant ineligible. Comorbidities, as I said already, presence of diabetes, heart failure, renal failure, or other comorbidities. What is the finances or insurance status of the patient? As I said, this treatment is lifelong, so we have to make a regimen which patient can continue. Even if there is a relapse, then he should have finances to continue the regimens. Nutritional status of the patient. Although serum albumin is a good parameter to classify the patient into different ISS, but some patients have very poor nutritional status because of many factors and poor performance status also, and hence you cannot give high dose chemotherapy to these patients. Fertility is other one which you can see and in the patient and then decide about the therapy. Some of the miscellaneous causes are like availability of drugs. Some of the drugs may not be available. Some of the therapies may not be available in that particular center or in that country. For example, CAR T cells right now are not available for myeloma patients in India. Monitoring facility. At some centers, they may not have to properly monitor the patient. Family support, I feel, is very, very important, which can really help the patients to go through the whole treatment. Okay, so now after knowing about what are the drugs which are available and the variables which affect the treatment, the questions which comes to our mind are, in the induction therapy, what is the best induction therapy? Whether we give 2 drugs, 3 drugs or 4 drugs combination. The good, whether the bortezomib is good or carfilzomib is good in the induction therapy. Similarly, in the IMiDs, thalidomide versus lenalidomide versus alkylator cyclophosphamide. What is the role of addition of anti-CD38 antibody like daratumumab in induction therapy? Then in consolidation therapy, what is the exact role of an auto hematopoietic cell transplant? And how long therapy to continue if transplant eligible or transplant ineligible? And in the maintenance therapy, whether you give single agent lenalidomide or double agents. So we will discuss some of these questions in the subsequent slides. The first question obviously is doublet versus triplet, and this debate was long settled in 2010 by this IMF study, which comparing the bortezomib with thalidomide plus dexamethasone. That means VTT compared with thalidomide plus dexamethasone as induction therapy before and consolidation therapy after double auto transplant in newly diagnosed multiple myeloma patient. This was a phase 3 randomized studies, and in this study there was a clear improvement in the complete or near complete response in patients receiving triplet versus doublet, and there was a overall survival difference. And based on that, in 2010, that means almost a decade back, therapy The standard of therapy was a triplet consisting of bortezomib, thalidomide, and dexamethasone. This was the editorial which was written by Paul G. Richardson in 2010. However, in India, we have been using a lot of centers were using or are still using bortezomib, cyclophosphamide, and dexamethasone. So VCT regimen. So there is a comparison with VCT versus VTT regimen. So both are triple drugs in newly diagnosed patients. This is a meta-analysis which is published in 2014. And in this meta-analysis, based on the different studies, although there is no direct comparison of these two studies, but from various other studies, the meta-analysis which was done showed significantly higher complete or near complete response, 34% versus 6%, as well as a higher very good partial response or better patients receiving VTD therapy versus VCD therapy. And this is shown in this table also. The post-induction response rates, VTD versus VCD, and you can see the CR or near CR rates and the VGPR rates are better with VTD therapy. So based on this, generally we do not recommend VCD therapy in otherwise fit patient of multiple myeloma these days. Then we had a comparison of Lendexa versus Botilendexa. This is a SWOG S0777 trial, which was published in 2016. And this regimen again, triplet were better than doublet. And you can see the confirmed response, very partial response are better in patient group who receive triple agent than the doublet. So the SWOG trial showed that all novel triple drug combination, that means bortezomib, lenalidomide, used in the absence of an auto transplant is superior to double novel agents in terms of PFS as well as OS. So from 2014 or 15 onwards, most centers in the world, people have shifted to Botilendexa, or what we call as VRD or RVD, as the induction therapy in newly diagnosed multiple myeloma patients. So in terms of overall response rates, VRD is better than VTT and then VCT. Although there is no direct comparison of VTT with VRD or VCT with VTT or VRD. Now, VCD still has a place, especially in patients who present with acute renal injury due to cause nephropathy. And here in one trial, which is published a couple of years ago, showed doublet versus triplet, comparing the Botidexa versus Botidexa plus cyclophosphamide. And in this trial, they showed that 3 months there was no difference. However, the study is not received very well because already the therapy which is proven is the triplet are better than doublet. However, what this study shows is that in patients with renal failure, bortezomib is the most effective, and whether you give VCT or VD, at 3 months the response rates are this, shown in this graph. So in patients presented with renal failure, VCT or VD is good enough for the initial therapy because the mortality is quite high in these patients, patients who present with renal failure. Now, what about quadruplet or addition of daratumumab and anti-CD38 antibody? Most of you may be familiar with the Cassiopeia trial, which is bortezomib, thalidomide, and dexamethasone with or without daratumumab. This is again a phase 3 study by the French group. It clearly shows that the stringent complete response and complete response are better if Dara is used upfront in the VTD regimen. So VTD actually is still the most common kind of a regimen followed in the European countries, and that's why they compare VTD with Dara VTD with VTD. Even the MRD negative status is better when you are using Dara upfront in the induction therapy. And you can see that this forest kind of a graph that it favors the DVTD regimen. So the interpretation DVTD before and after auto transplant improves depth of response and PFS with acceptable toxicity safety. Now, similarly, we have a Griffin trial. It's a phase 2 trial which comparing Dara Len Boti Dexa with Boti Len Dexa versus Dara VRD, and here again this shows the MRD negativity rate are better with when you use Dara in the induction therapy. And in this forest kind of an analysis, Dara RBD is better than RBD in terms of most situations, including in high risk. This is the percentage surviving without progressions. You can say 89 versus 95, RBD versus Dara RBD. So in the Griffin trial, the DRBD improves stringent CR rates and MRD negativity versus RBD, both which deepen over time, and there are no new safety concerns. So addition of daratumumab in VTD or VRD induction does lead to increase in the MRD negative rates. Now the survival is so long, whether this will ultimately improve the overall survival or not, we don't know. Only the time factor will tell, but there is a definite difference between the PFS. Now the other commonly asked question is which proteasome inhibitor to use, carfilzomib or bortezomib upfront. And there was a lot of hype last year about this 48 trial, which is a phase 2 trial comparing carfilzomib with cyclophosphamide and dexamethasone versus carfilzomib lendexa plus auto, carfilzomib lendexa followed by maintenance with carfilz plus len. So 3 drug comparison: carfilzomib, cyclophosphamide, dexa, carfilzomib, lendexa, and then in maintenance carfil len versus len alone. So in this trial, the good thing is the overall response rates were quite good, more than 90% in all the 3 arms. So KRD followed by transplant, KRD 12, and KCD. However, when you decipher it further, obviously KCD is inferior. So as I said previously, so VCD and KCD, that means cyclophosphamide upfront is inferior in terms of achieving response rates as compared to len or fel. However, when you look at the MRD, the transplant, obviously initial KRD followed by transplant does lead to better MRD negative rates, 69% versus 80%. In the maintenance therapy also, even though both are equal, but you can see some difference in the response rates when you're using len versus carfil plus len. Especially this is useful in those patients who are high risk. So this is the progression-free survival, and you can see KRD plus followed by transplant is way ahead with the KCD plus transplant, and similarly in the maintenance therapy, carfil plus len is better than len alone. The p-value is 0.023. Obviously, then you add DARA to this regimen. So what happens? This is a master trial, which is again published last month only. DARA, carfil, and dexa, and this trial is also looking at the MRD, whether you can stop the maintenance if the person is MRD negative. So you can see these graphs. The people with the high risk cytogenetic abnormalities, they did better than those patients with ultra high risk And in these patients, if they are MRD negative, they have stopped, and obviously we would know on follow-up of these patients. So, for patients with 0 or 1 high-risk cytogenic abnormalities, this strategy creates the opportunity of MRD surveillance as an alternative to indefinite maintenance therapy. So, based on these studies, the summary is even though carfilzomib appears to be superior to bortezomib in the upfront setting in high risk, the risk benefit in our setting is debatable. As if you remember, the cost effectiveness is very, very important in these patients. Probably, if you ask me theoretically, I would say young patients who has no problem in finances, maybe high risk young patient is the best person to receive carfilzomib based induction therapy. So the induction therapy is quite centered around achieving stringent CR and or MRD negative status. So I think it is a good time to revise the response criteria in myeloma, which are given by eye interpretation. So the PR rates is when there is more than 50% reduction of serum M protein, VGPR when it is M band is negative, there is 90% reduction, but immunofixation is positive, and the CR rates are negative immunofixation on serum and urine, disappearance of plasmacytomas, and less than 5% plasma cells in bone. Stringent CR when there is a normal relation ratio also, and there is no global plasma cells. MRD negative by flow or next generation. This is all deeper remission which these days we focus on, because deeper remissions actually lead to prolongation of survival. So the MRD negative status, if you're using VTD, DARA VTD, VRD, DARA VRD, KRD, and DARA KRD, look at as you intensify the therapy, the MRD negative rates goes up. However, again, this is quite costly, and I'm not sure whether in Indian setting, how many patients can afford this kind of a regimen. So summary of induction therapy, VRD or VCD in case of renal failure and upgrade to VRD if creatinine normalizes, add DARA in induction if affordable, KRD in high-risk young patients if affordable. Now the next question is duration of induction therapy. You generally take up the patient for an auto SCT, which is a consolidation therapy after 4 cycles. But sometimes in our setting, patients take time and can continue up to 9 cycles this regimen. And however, lenalidomide can be dropped in standard risk patient after 6 cycles, whereas in high risk patient have to continue then or replace with thalidomide or cyclophosphamide. We don't know the outcome of those patients. That is a meeting of research. So the impact of duration of induction therapy on survival in newly diagnosed patients. So 2 cohort, they looked at where they irrespective of response took up the patient after 4 cycles of transplant versus when induction therapy was continued for more than 4 months, and there was no difference in overall survival in the 2 groups. So this paper concluded that you don't actually prolong you don't look at the response, waiting for VGPR or PR or CR. Just take up the patient for transplant. So for transplant ineligible patients, so generally the therapy is continued for 6 to 9 cycles, and the other option these patients are instead of bortezomib, you can use DARA, then DEXA, which is actually a very good kind of a regimen, and you can see the PFS comparing Lendexa with Dara Lendexa. And this is a Maya trial and L-Simon trial. Again, they look at the MRD negativity rates. People who are MRD negative are doing much better than those patients who are MRD positive. So induction therapy in Indian setting, VRD, DARA VRD, KRD, transplant ineligible, DARA Lendexa or VRD light. I generally prefer VRD light in most of these patients. So the consolidation therapy is generally with transplant, and This is one of the landmark paper from the French group looking at the VRD and transplantation. So here they gave 3 cycles of RBD, then consolidation therapy, either 5 additional cycles of RBD or high dose melphalan with transplant. You can see the transplant group did better in terms of complete response as well as MRD negativity. However, the overall response rate is the same, meaning thereby that you can do transplant upfront or even delay it. The response rates are obviously better if you do the transplant. So the PFS is definitely better if these patients are taken up for consolidation as transplant. Whereas the OS is not different because of the availability of better therapies, therapies. So consolidation therapy, transplant with melphalan 140 to 200. For ineligible patients, you continue 6 to 9 cycles. So this is a consolidation therapy for these patients. The maintenance therapy is clear after the publication of these reports that LEN is better than placebo, both in terms of PFS as well as OS. And we have a CalGB Alliance study also, again looking at the same. The LEN is better in terms of PFS as well as in OS. So the algorithm which is given by Vincent and Shaji is they are dividing into standard risk, intermediate, high risk. I would say that 14 is now also taken as standard risk. So you give VRD or DARA VRD based regimen in these patients who are transplant ineligible. Continue with therapy indefinitely. Generally for high risk, you consider double body and LEN as maintenance. For transplant eligible patients, 4 cycles, collect cells, take care for transplant. That's what happens in other patients, and continue then I will say indefinite therapy, or sometimes you can give both of them together. So concluding, we have come a long way in the treatment of myeloma. Median survival from less than a year now is more than 10 years in low risk myeloma, the standard risk myeloma. The induction therapy in current era consists of proteasome inhibitor with IMiD and corticosteroid triplet, and you can have DARA if the patient is affordable. Transplant eligible patient undergo auto transplant after 4 to 6 cycles of induction. Patient achieving MRD negative status at day 100 have excellent long-term outcome. All patients post-transplant get either LEN or BOTI or both based maintenance therapy indefinitely until progression or intolerability. Transplant eligible patients get continuous therapy at least for 9 to 12 cycles, followed by maintenance therapy indefinitely until progression or intolerability. With that,
This talk, I think we have just come to the time given for this talk, and I don't see any. Am I audible?
Yes, sir, you're audible.
So I don't think there is much of questions. So it's already 11:55, and I think I'll let this go to the discussion part by Dr. Vasudev Bagal. Professor.
Thank you, sir.
Yeah.
Yeah, thank you, Pankaj sir, for a comprehensive talk. I don't see any questions in the chat box, sir. And before I proceed, Dr. Nandi or Dr. Prasad, do you have any questions for sir?
No, I think you can go ahead.
We can proceed.
So, sir, one quick and which is probably the most frequent question which is asked is daratumab showing some activity in upfront setting, especially the non-transplant eligible part. So do you see any subset which would particularly be benefiting by DARA, and you would be probably insisting on treating such patient with daratumab in the first go, sir?
Thank you. Sorry, actually today there were 2 meetings, so I recorded this presentation yesterday, and what I could see there was some disturbance, so I'm sorry for that. I hope you were able to get some idea about the presentation. But I think we can clarify some of these questions, and this question which you have asked is very valid about adding daratumab upfront
in the induction therapy. So as I said before, in our setting, the DARA is quite costly. It is very difficult to actually to answer whether to add DARA upfront in if you are giving VRD regimen or not, but probably somebody who is high risk cytogenetics, where we feel that achieving an MRD negative status is very, very important. Maybe in those setting, I would say that we can add DARA if the patient is affordable. In a standard risk patient, it is okay if you use VRD or DARA VRD.
Yeah. So besides cost, another concern is tolerance of our patient, because they come with many times renal dysfunction and infection quite alike. So, and there is some data from your centers also. Do you see any increased risk in our patient when we use DARA across the board for all our patients?
So we recently just completed, looking at the infections risk in these patients. The infectious mortality in the first 60 days in our patient is approximately 20.5%. And in this COVID era, actually quite a good number of patients had COVID infection also. And patients who had severe COVID, in fact, nobody survived, whereas patients with mild to moderate COVID, they survived. We have now started, a regular practice of giving pneumococcal vaccine as well as flu shot to all these patients. We did almost a similar kind of a study 2 years back also, where the mortality was quite high. And now with the routine immunization, we have seen that the mortality has come down. So I would suggest that, we should try to push immunization of all these patients of multiple myeloma, even though we know that they may not form the proper antibodies as compared to the normal people. But still, I think giving immunization to these patients is important to decrease the mortality, because infectious related mortality is, is still high in our population. And obviously, if you're adding DARA to that, which suppresses the plasma cells, and it suppresses the normal plasma cells also. So obviously the immunity is going to go down.
Yes, sir. So thank you for that very important message from your study, sir. Sir, last question, which is not really related to the upfront setting. We have this Bellini trial and a bit of disappointment there, sir. But if you look at the hazard in translocation 11-14 and BCL2 overexpression, it is 0.12, which is quite impressive hazard. So do you see this drug is being repurposed or would be studied further, or do you think it's end of when in multiple myeloma?
I think so that, for 11-14 patients specifically, even though, in the Bellini trial, they looked at the overall survival, which was lowered in those patients. However, in the subset of patients of 11-14, definitely it made a lot of difference. So I would say that even though, you may not use it in the upfront setting or in the first relapse setting, but definitely this is a good drug to be used in the second or subsequent relapses, particularly in 11-14 patients who are either myeloma patients or amyloid patients.
Yeah. Thank you, sir. And in view of interest of time, I hand it over to Chairperson. Thank you.
Thank you.
Thank you. We will now hand it over to Sachin to invite the next talk people.
Thank you so much, Dr. Prasad. And for the next session, I be inviting the chairperson, so Dr. Rajeshwar Singh. Is the Department of Medical Oncology Director from Paras Hospital, Panchkula. Dr. Ramesh Nimagatta, very well-known doctor, is the Managing Trustee and Senior Consultant Medical Oncologist from Ramesh Nimagatta Cancer Foundation, Chennai. Due to some emergency, Dr. Rajeshwar couldn't join, so I request Dr. Ramesh to invite our next moderator for the panel discussion. Over to Dr. Ramesh.
Thank you. First, I would like to thank the Jyoti and the organizing committee to give me the opportunity to participate in all these sessions. And I think we are getting to the last session, and this is going to be the panel discussion on T-cell lymphomas and management. And Dr. Manju Singh, everybody knows, she's the professor at the Department of Medical Oncology, Tata Memorial Hospital. She's going to moderate this session. Manju, maybe she can call the people, or are you going to invite the panelists?
Yes, sir. So Dr. Hari Menon, Dr. Ghanshyam Biswas, and Dr. Rajiv Kumar are there for the panel, sir. And I requested Dr. Pankaj Malhotra also to stay for the panel, and so as Dr. Puneet Chen. Over to Dr. Manju Singh.
Thank you, organizers. Thank you, Dr. Smriti, for the kind invitation, and Dr. Nimagara for that kind introduction. I know that many of our panelists have dropped out, and I'm really thankful to the lead discussants and the other participants to stay back and help with this panel. If I'm right, Sachin, Dr. D.K. Mishra has not joined, right?
Yes, ma'am.
Okay. Okay. Will you allow me to share my screen? Yeah, thank you.
Yes, ma'am. Yeah.
So what we'll do in this panel discussion is to take some common scenarios for the mature systemic T-cell lymphomas. I do have 3 cases, but depending on the time we have and whatever discussion goes on individual cases, we can decide whether we want to go ahead and take all 3 or restrict to only first 2 cases. The minute we see a diagnosis of T-cell lymphoma, for both oncologists as well as for the patients, it's little unsettling. And I think, though Dr. D.K. Mishra is not here, but even for pathologists, the same feeling comes in for many cases. And the reason for that is that there is so much wide variety. There is so much, what you call plasticity in the T cells, as well as in the microenvironment, which makes both the diagnosis and the management really difficult. And on top of that, these diseases are rare. So if you club all T-cell lymphomas, they are only 15 to 20% of all lymphomas. But if we talk about several of these individual entities, it's even rarer. So we don't get to see a huge trial addressing the concerns of patients who have T-cell lymphoma. So with that, I'll begin the first case. I did have few pathology cases, so I'll request all my clinician friends to chip in when we ask for pathology questions. So this is a 54-year-old male who presented with B symptoms, significant amount of weight loss for last 6 months and fever, which was almost 101 and 102 daily for last 3 months, with occasional pruritus. On examination, performance status was 2, and there were bilateral, cervical, axillary, and inguinal lymph nodes. The largest lymph node was 3 centimeters in the left axilla, and the liver was palpable around 4 centimeters below costal margin. Spleen was not palpable. There were no comorbidities. On evaluation, the CBC was showing hemoglobin of 8.4 with normal indices. TLC was 10,500 with predominantly neutrophils and low absolute lymphocyte count. Liver function tests revealed bilirubin of 3, which was predominantly direct, marginally elevated OT and PT, and serum alkaline phosphatase, low albumin, high serum LDH. Lymph node biopsy from the left axilla was suggestive of effacement of lymph node architecture with polymorphous cells. There were interspersed large cells, which were CD45 positive, 30 positive, 20 negative, CD3 positive, and ALK negative. So a diagnosis of ALK negative ALCL was made. Further investigations were done, which again confirmed the suprainfradiaphragmatic lymph nodes. There was splenomegaly with focal lesions, and bone marrow biopsy was uninvolved. With that, I'll just want to ask, this concern which comes in terms of diagnosis of any T-cell lymphoma. How do you think that a histopathological diagnosis of anaplastic large cell lymphoma is made? I know it's a pathology question, but many times we are the one who are at the receiving end, and we need to interpret, what is written in pathology report is important or not. So maybe I can just request Hari to start, and if anyone wants to chip in, they can chip in.
Thank you, Manju. But histopathology for a PTCL is even tough for the pathologist. So you're asking me a tough question.
Sympathies with you.
Yeah, but yes, we rely heavily on some of the morphological features that we do come across, and we do encounter certain patterns over there, like you have got something like the lymphohistiocytic pattern, and you have the small lymphocytic pattern, and also a Hodgkin's lymphoma-like pattern also, which is over there. And then you have the characteristic hallmark cells that you see on the histopathology, these things. But we rely heavily upon we rely heavily upon the immunohistochemistry over here. Of course, they are pan CD30 positive. And they are, of course, when you're putting the markers with the suspicion, they are definitely ALK negative. And then when you are looking for some of the molecular markers, we can discuss the molecular markers later. But these are the things that will actually make us think that here we are dealing with anaplastic large cell lymphoma, which may be ALK negative over here. But there are so many types of cells that have been described, like there are those fried egg cells, wreath-like cells, and so many other things that have been on morphology described. But with a clinical suspicion, you go on to the immunohistochemistry, which sort of percolates down to give us crystallizing into a diagnosis, and then which is helped down the line with some of the molecular markers also. Yeah.
Thank you, Hari, for showing that bravery and taking this question. Just, I was expecting Dr. Mishra, but just want to show that, typical anaplastic large cell lymphoma, whether we talk about ALK positive or ALK negative, has, more of cohesive pattern. There is effacement of nodal architecture. And you do see these, large cells, we call them as hallmark cells. And once we do the immunohistochemistry, some of the times you may just have these neoplastic cells limited to intrasinusoidal region. And typical IHC, as Hari mentioned, that it's CD30 positive. There is diffuse positivity of the membrane and the perinuclear area. You have loss of one or more T cell antigen. So you can have, 5 negative, 2 negative, or 7 negative. ALK is negative as opposed to ALK positive large cell lymphoma. They do express cytotoxic markers like perforin, granzyme, and TIA. So, and CD8 can be positive in these anaplastic large cell lymphoma. So this is a typical anaplastic large cell lymphoma, but many times it's not very easy to differentiate this from the other, PTCL categories, except that CD30 positivity here is much stronger, and you get to see these cytotoxic markers and EMA positivity, which can help in making a diagnosis of PTCL versus anaplastic large cell lymphoma, ALK negative or ALK positive, depending on the immunohistochemistry for ALK. Is there any subclassification of ALK negative ALCL which you ask in your clinical practice? And if yes, what is the value and how do you do it? So maybe I can take Puneet on this.
I don't have, unless you do a more molecular classification to look at the differentiation and the prognostic impact, I don't think anything else I have to offer here. It's just that we look at the extra molecules that would characterize its prognosis. I don't have anything more to say on that.
So can I take so there are certain morphological features that have been described in these, like of course the staining pattern, of course, is typically membranous, and there is the Golgi staining region over there which is diffuse. And then you do have these things described, like while small lymphocytic variants are more common in ALK positive, but they are seen in ALK negative also. You have the lymphohistiocytic variant and the third variant, which is like a Hodgkin's like variant of ALK negative ALCL. So these are what the pathology is described on histopathology. And of course, we need to corroborate subsequently with some of the other markers to distinguish it from the ALK positive ALCL over here.
So as Puneet mentioned that, some of the molecular features which can help further differentiate between different ALK negative ALCL. So I'll just take up Dr. Biswas on this. And so what molecular markers, it may not be available or may not be done routinely, but if let's say we have the facility, whether that will help in, further subdividing these and prognosticating.
So, good morning, Hari and Manju. So ALK negative is also a heterogeneous group, so they may not behave like the ALK positive we know, but still there is a cohort of ALK negative, especially that is DUSP22. So a rearrangement can behave like the ALK positive. And the other molecular is a TP63 positive, so they will behave like a true ALK negative. So at least these two markers and the TIA, if that is also negative, so there is a cohort of triple negative also.
Sure. So thanks, Dr. Biswas. I'll just highlight what Dr. Biswas just mentioned, that if you look at DUS22 rearrangement and TP63 rearrangement, you get a clear distinction between a very good behaving anaplastic large cell lymphoma ALK negative versus that is, which behaves really poorly. So the outcomes for DUS22 are as good as ALK positive. And in this study, it was almost 85% 5-year progression-free survival, as opposed to for TP63, it was around 17%. And the rest, which is somewhere in between, is, the outcomes are also in between. And this can be very well done with the help of FISH itself. So there is probe for DUS22, there's probe for TP63, which can be evaluated at baseline, and this can help us in terms of prognostication. What I must tell is that this is all before what we are talking about brentuximab use. So this is the data which is there from the CHOP and CHOEP, patients who have been treated with CHOP and CHOEP. So that's where this data comes from. But yeah, it does look like a favorable disease if you have DUS22 rearrangement. Can we suspect this, or do we need to order for everyone? So if you have DUS22, there are certain characteristic morphological features, and this is what we call as, these hallmark cells look like donut cells with, predominant perinuclear inclusion. And as I was discussing that in ALK negative ALCL, you do have cytotoxic, features, CD8 positive and the other granzyme perforin and TIA. These DUS22 rearranged ALK negative ALCL lack that. So that way one can suspect that if you have ALK negative ALCL and you have these features, then you can confirm by doing FISH that whether there is presence or absence of DUS22. We'll move on to another question, which is which bothers all of us. We keep on telling our pathologists that tell us whether it's ALK negative ALCL or PTCL NOS. Do you think that there is a clinical relevance in terms of how you're going to treat or how you're going to prognosticate, whether there is any difference? So I'll move to Dr. Rajiv and request him if what are his thoughts regarding distinguishing from a clinical point of view between ALCL and PTCL NOS.
Thank you, ma'am. The therapy would actually remain almost similar since both of them are difficult to treat cases. If possible, and as and when feasible, if we are able to add brentuximab into the anti-CD30, then it will be good. But in our cases, we end up using CHOP or CHOEP. So we have a patient who I've just recently, we just started him on CHOEP right now. But the only difference would be in terms of prognostication. If it's ALK positive, it's well known that these patients fare better when compared to PTCL NOS, when compared to ALCL. So hence, that differentiation would be necessary for us to prognosticate. And in both of these conditions, as and when feasible, if we are able to induce remission, we take up the patient for transplant. I feel that we would be able to, only the prognosis changes. The therapy would remain more or less the same.
Sure, thank you. So I agree that treatment won't change much, but differentiating ALK negative ALCL from PTCL does help in prognosticating the patients, and ALCL ALK negative does better than PTCL NOS. But this is again, as we were discussing more with CHOP and CHOEP, and we have to see how much it really matters when we talk about brentuximab. So I'll take up another case and then we'll move on to the treatment. So this is a 63-year-old lady who's been having constitutional symptoms for last almost 7 to 8 months. Now for last 1 month, she started complaining of cough and dyspnea on exertion. Performance status is 2. There is generalized lymphadenopathy in cervical region, axillary and inguinal region, but none is more than 1.5 centimeters. Clinical examination reveals bilateral pleural effusion, and there is spleen which is around 6 centimeters below costal margin. The initial investigations show hemoglobin of 5.2, total leukocyte count of 9,800 and platelets 5,60,000. And there is reversal of albumin globulin ratio with high LDH, and she has direct Coombs test positive. The lymph node biopsy here was suggestive of angioimmunoblastic T-cell lymphoma, and that was mainly on the basis of that there was 4 positive, 5 positivity, 10 BCL6 positivity, and there was polymorphous background infiltrate along with high endothelial venules. So this was the diagnosis, and I am not going to put anyone on the spot for this pathology here, and just take up that we have now 3 types of T-cell lymphoma, which are under the category of follicular helper T-cell lymphoma. So I'll discuss that, what those are, but just a question. So here is a elder, more than 60-year-old lady with significant constitutional symptoms, compromised performance status. What additional workup would you recommend in her with the diagnosis of AITL on lymph node biopsy? Anything additional would you suggest? So Hari, I can start with you, and then maybe we can go around to Puneet and.
Yeah, so basically the workup doesn't differ from what we would for any of the lymphomas that we approach. We would like to stage the disease, and also more importantly in this situation, try to distinguish it whether there is an angioimmunoblastic T-cell lymphoma, because marginally they may do better than the peripheral T-cell not otherwise specified. But that is again in terms of the prognosis, and also so staging is important over here. And sometimes if you have a more local regional disease or early stage disease, there is a suggestion that they may do better, and some sort of a treatment in terms of even using epigenetic therapies like azacitidine, hypomethylating agents, etc., might benefit these patients. But I don't believe that there is any difference in the way that we work up these patients as against any other lymphomas. And there is a propensity for bone marrow involvement over here, definitely.
Puneet, any difference of opinion? And I can see Dr. Pankaj is also here, so I'll catch Dr. Pankaj also.
From my side, I think I agree with Hari sir. No major additional workup. I mean, those patients who might be Coombs positive, we sometimes tend to do an autoantibody panel. But other than the bone marrow and a PET CT, that's I would opt, because the treatment probably will not change so much. So I wouldn't offer at least more than what is being already done.
Is Dr. Pankaj around?
So yeah, I think generally in the first patient also, which there was also albumin globulin ratio which was altered. So here also it is altered. So it is good idea to do a serum protein electrophoresis, immunofixation, and immunoglobulin levels in these patients. Although it is not, your therapy may not change very much, but if you do these run the electrophoresis, I also prefer to do ANA in patients who have AITL. And if these are positive, many of these patients actually respond very well to cyclosporine therapy, which generally you do not give upfront. It is only generally in the relapse setting, but you have your options in front of you. In PTCL or AITL, where we know the outcome is not very good, whether you use CHOP or CHOEP therapy. So as just for a more understanding of the illness, it is good idea to do autoimmune workup, ANA and serum protein electrophoresis in these patients.
Thank you. So this patient, and as I said, that this is what everyone wants to do. And as Dr. Pankaj added, that we want to have immunoglobulin levels, SVP and ANA. Does anybody perform any molecular test in patients who have AITL?
So yes, ideally, so we need to rule out EBV associated. There are certain additional molecular markers like IDH2 and certain others like RHOA or something like that.
So the RHOA is almost uniformly mutated in these patients, and also that I forget the TBX2. Kamanju, you can correct me. That is also probably sometimes positive, and patients who have the TBX2 probably do a little worse than the other. But I'm standing to correction because this is just something that I've read a little while ago.
No problem. I think we're all in the same boat. Everyone does the same thing. So as we were talking about the follicular T helper cell kind of a lymphoma, there are three categories. And depending on, if they typically have, this is the panel which is recommended. So if you have CD30 negative or variably expressed, you do CD4. And the next panel include all these T follicular helper cell markers, which is BCL6, CD10, 20, and CXCL13 and PD1 and ICOS. And if you have two or more than two of these follicular helper T cell marker, they come into this category of AITL or nodal PTCL or follicular T helper cell type of peripheral T cell lymphoma. And if you have less than two, then they fall in the category of PTCL. And as we were talking about the molecular markers, as Hari and Dr. Biswas both mentioned, that the ROA is something which is quite sensitive and specific for AITL and follicular T helper cell lymphoma. But more than that, it's the IDH2 mutation, which is typically seen in patients with AITL. So more when we have diagnostic dilemma, probably this can help us. As of now, we are not distinguishing anything which is biomarker-driven therapy fully in the field of peripheral T-cell lymphoma or AITL, except for looking at CD30 positivity. This doesn't have clinical value, but yes, it can help us in making the diagnosis when you have other features which are not really completely fulfilling, because we know that AITL over a period of time evolves. It may not have the typical morphological features what we are describing here, and that's a place where it can help. Everyone said that PET-CT is needed and bone marrow biopsy. Completely agree. For all T-cell lymphoma, PET-CT has significant FDG uptake at baseline, so that should be considered. There is suggestion that total metabolic volume can have prognostic implications, but again, not validated in any prospective studies. PET-CT really doesn't pick up completely the bone marrow biopsy. So as opposed to Hodgkin's and to a certain extent in DLBCL, where one can avoid doing bone marrow biopsy, PET-CT is showing or not showing the disease. Here in T-cell lymphoma, it's important to complement PET-CT with a bone marrow biopsy. One additional thing which we do in our patients, and we have seen a significant number of AITLs having CMV DNA viremia. And these patients do respond to antiviral therapy. We do use ganciclovir, not as only therapeutic options, but that takes care of a lot of their B symptoms and constitutional symptoms. So we do CMV DNA in these patients. So coming on to the workup for this patient, we had supraintradiaphragmatic lymph nodes, which were non-bulky, as it was evident on clinical examination too. There were bilateral lung nodules, pleural effusion, ascites, and there was marrow uptake in the multiple vertebrae and pelvis. Aspiration and flow was suggestive of bone marrow involvement. So question is, how do you prognosticate peripheral T-cell lymphoma in general? I'm not talking about NK T-cell lymphoma, I'm talking about peripheral T-cell lymphoma. How do you prognosticate, and do you differ from what you use in the aggressive B-cell lymphoma in terms of DLBCL, or you use the similar prognostication methods? So again, I'll start from Puneet and then go to others.
Yes, thank you for the question. I think it's the staging which is probably going to matter the most. The bone marrows, the PET-CTs, and then when possible, do the molecular markers, and that because our treatment panel will probably remain same, CHOP or CHOEP, and then followed by an autologous transplant if ALK negative PTCLs, or even if it is a PTCL NOS. That's how I would approach. In an ALK positive patient, obviously there are no need for an autologous transplant upfront. Just continue with CHOEP and then follow up. That's what I would do.
So any differences of opinion, Dr. Biswas, Dr. Rajiv?
If it is a PTCL NOS again, so that becomes a molecular typing of GATA3 versus TBX21, because GATA3 will be more of a bad disease. So where there are newer therapies like the PI3K kinase inhibitors. And if it is a TBX21, so we know that there are they will do good. And we have novel agents like the JAK2 inhibitors or the STAT3 inhibitors.
I would just like to, sorry, ma'am.
Please.
This is technically what we're saying is correct, but actually in practice, like in a regular practice, how much are we able to do these tests? In the sense that whenever we have this, we have a ALCL, or when we are happy that we have been able to differentiate whether it's a PTCL and an ALCL, and then afterwards go ahead. So the prognostication, like how we just discussed, is that again, if the marrow is involved, it's a much more poorer prognosis. We're not going to be able to give the full therapy. But the other molecular markers, are we getting it done in regular practice? Is it actually practical? So in what Dr. Biswas has told us, it's very perfect in the sense to be academically sound. But in practice, may I find out, like, what are we doing? What are we doing? How are we actually
I am with you, Dr. Rajiv, on this. So we end up just looking at the basic clinical parameters, the radiological parameters, and the blood parameters, what we usually use in prognostication. Coming on to the molecular or further subtyping based on the molecular parameters. So except for DUST22 and TP63, which we use, nothing additional is done in the routine clinical practice for if we club all peripheral T-cell lymphomas together. So yes, for academic purposes, for putting them under a specific category of PTCL or in follicular T helper cell lymphoma, we have these facilities, but you're absolutely spot on that the management stops at just distinguishing them and planning therapy based on the clinical, biochemical, and the radiological parameters.
Madam, what are you sending the marrow? Are you sending peripheral blood? Are you sending on the lymph node? How are you actually checking for these molecular markers?
So for DUST22 and for TP63, we do it FISH on the lymph node biopsy.
Okay.
Yeah.
And any particular, all labs are doing it, or is it only in a research center like Tata?
So I think this probe is basically a FISH probe, and any particular center which has relatively good amount of lymphoma volume, I guess they have. So it's not anything which is limited to TMH. So okay. That's something which, and it's not that for all patients we do it, because even for FISH, there is cost involved. So unless we are really thinking of whether to continue treatment or not, so very select subset where we request for doing these markers.
Thank you.
Yeah. So what I was actually trying to get is the clinical prognostication which we are looking at. So IPI which we use for, or age-adjusted IPI which we use for diffuse large B-cell lymphoma. As opposed to that, there are several prognostic scoring, and as you can see on the slide, from PIT to modified PIT to international T-cell index to T-cell score. There are several features, and as you can rightly see here, that none of them have molecular markers included, except for one which has Ki67 of more than 80%. So rest everything is basically based on clinical parameters or the biochemical parameters, which again goes on to say that we are still understanding most of these molecular markers and their clinical utility for PTCL overall. So this is what is done. I'll move on to the treatment part. And as our first patient, who was LCL ALK negative in his 50s, has stage 3B disease with an IPI of 3. And if we look at the T-cell score, that is 3. So how would you manage? And I'll start with Hari, and I'll just try and understand that if the same patient was young patient in his early 20s, whether your management would change or it will remain the same. So ALK negative ALCL, this patient and the younger patient. Hari, and then I'll go on to the others.
So thank you, Manju. And the thing is, I would not treat it differently if it was older patient, but you would put a clause about younger patients. So in older patients, I would just go ahead with the standard therapy with CHOP over here, keeping in mind that should if they are having a good prognosis, they are bound to do well with the CHOP protocol. But if they are if they do not have those favorable profile in that negative, then even though there is not any strong data to say that intensification of therapy works, I may be skewed towards using a more intensive therapy. So I know that when I was there at Tata, we used to use more intensive protocols for young patients ALK negative patients below the age of 30, we used to think about using patients with the BFM 90 protocol, which was an intensive protocol over there. But largely, we have become a little wiser and realized that maybe using most of the patients would do well with the standard CHOP protocol over here.
I can see Dr. Pankaj is still with us. So I would like to ask you, what would be your opinion on treating this patient? Hari said CHOP, and let's presume that we have brentuximab available in India. We not really need to import, so it's available and you can prescribe. So what would be your preference? And
no, you are right. You are absolutely right. So if brentuximab is available, then obviously brentuximab with CHP therapy is kind of a standard for ALCL nowadays. Although Hari is right that out of our 100 patients, probably 99 will still go for CHOP therapy or CHOIP therapy only. But definitely, if brentuximab is available, I would like to use brentuximab based on the available data.
So I'll take an extension of that question itself. So if you're using brentuximab, would you be looking? So we know that ALCLs are all CD30 positive, but if you're talking about, let's say, PTCL in this scenario, would you be looking at any particular cutoff for CD30, or any expression would be fine?
So I feel that ALCL definitely brentuximab irrespective of expression, but in PTCL NOS, unless the expression is more than 30% or 40%, it's some study says 30%, some says 40%. There I would not. There the use of brentuximab is not very, I would say, forthcoming, but in ALCL definitely.
Sure. Any difference of opinion, Puneet, Dr. Rajiv?
Madam, if I would ask, it's like Hari Menon sir mentioned that he would like to do CHOP, and since that, why not CHOP? It's a young patient, so you hit him hard. You know that with CHOP, these patients would have some amount of remission for probably 6 months. And if you're unable to take them for a transplant, then it will be a very short-lived remission. So wouldn't you want to hit him with a much more harder regimen? So
what harder regimen would you recommend?
With CHOP, in the sense that, yeah, CHOP.
Okay.
Can I interrupt? Sorry.
Yes, please.
Because everybody's here, I would actually like to ask, what about the autologous transplant in a situation like this? Post CHOP, if you are going to ensure ALK positive, yes, there is no role for an autologous consolidated transplant. But what about all the other types of PTCLs?
Thank you for bringing that question a little ahead, which I was coming a little later. No problem. Yeah. So I'll start from the transplanters.
So I believe that if you are with the data that's available, ALK negative with a DUST-T2, they behave as well as an ALK positive ALCL. So there's really no need to there. We are not sure about ALK negative patients who are negative for DUST-22, but then intuitively we tend to use a more intensive protocol in the beginning, and then if you're using a more intensive protocol and if they fail that therapy, I don't believe that autologous transplant is going to add too much, because if you look at the story from the peripheral T-cell lymphomas also, again, it is a little divided regarding the role of or the benefit of doing an autologous transplant in peripheral T-cell lymphomas. And if you were to look at it more in depth, those patients who actually responded well to primary therapy, they were the people who went on to benefit with an addition of high-dose chemotherapy and stem cell transplant. But if those patients had an early relapse or they did not fully respond, transplant did not add too much to the outcomes of these patients.
I'll come back to Dr. Pankaj again.
Yeah, so definitely for PTCL and ALK negative, patient should be offered an auto transplant, whether you use CHOP therapy or CHOIP therapy. Practically, I don't know, we CHOIP is obviously a little bit more toxic therapy, but whether it really makes a difference or not, or it is just, we're feeling that, if it is a young patient, so, you would like to give CHOIP therapy to that patient instead of CHOP therapy. We all do, I think, in our practice. But I think the important thing is to offer an auto transplant in all these patients who are ALK negative and a PTCL NOS, especially if they are young, less than 50 years of age.
Sure. So this is, the basic, thought most of us have that, CHOIP works better than CHOP. But if you look at, this is the data from where that, the genesis of CHOIP is, and this is retrospective data. And if you look at the difference between etoposide and non-etoposide, it was mainly limited to the younger patients, normal LDH. And it was predominantly, if you see the p-value, it was mainly for the ALK positive ALCL. If you look at rest of them, it's borderline significance, and the p-value here is 0.057. And definitely not for the older individuals, older who are more than 60 and those who have raised LDH. So even if we go by this retrospective analysis, I think the best benefit which is limited is to the ALK positive. Those who are younger and normal LDH is where probably etoposide works. But I agree with Rajiv, many times we feel that, CHOIP is going to do better, and especially those who have extensive stage of disease, we tend to use CHOIP, especially if we don't have feasibility of using brentuximab. Coming on to the question of, DUS22 here, I think if you have DUS22 positive, probably you can avoid using brentuximab there. Probable. I don't have any hard data to say that it's going to be less effective there. But since the outcomes are quite good, even without using brentuximab, that's probably the set where you would want to use that money of brentuximab and do FISH at baseline and see whether you can just do away with CHOP and CHOIP in these individuals. Another point of what we were discussing is whether younger patients, we want to do anything differently for this subset. So actually what we do in up till 25 years, which we treat more like AYA and on the pediatric protocol, we've been using ALCL 99. So as Hari rightly said that when he was there, we were on BFM 90, but the challenges were of high dose methotrexate, the mucositis, the cytopenias. We've moved to ALCL 99, and the basic difference there is you use a lesser dose of high dose methotrexate there, and 1 gram per meter square over 24 hours and no intrathecal therapy. So that's one advantage of ALCL 99. You have lesser toxicity, and data in pediatric with ALCL 99 is quite good, almost 70% plus 5-year survival, and this is even in the advanced stage disease. So that's one difference which we do. And when we were talking about the brentuximab, and now we have long-term follow-up 5-year data for the Echelon-2 trial, and you have both PFS and OS benefit. But I just want to highlight that this is predominantly driven by the anaplastic large cell lymphoma. 75% of these patients were anaplastic large cell lymphoma. They used a cutoff of 10% for CD30, though in the later analysis, they said, even if you have CD30, which is lesser than that, it really works. What it clearly shows that it doesn't work so well for AITL. We don't know whether it's truly the result of the low numbers. That's the reason why there is no difference, or it's it's really that the CD30 expression is really very variable here, and that's the reason why brentuximab doesn't work. So this is for the data. Novel agents, and as Dr. Pankaj was mentioning regarding cyclosporin. So I'll just come to that AITL lady who's 62 years and has all the features which say that there is significant autoimmune burden in terms of autoimmune hemolytic anemia, reversal of albumin globulin ratio. There is polyclonal hypergammaglobulinemia in that lady. There was no monoclonal gammopathy. So my question is, how would you handle that lady, 62-year PS2, frail, extensive disease? Do you think that the conventional CHOP CHOIP, brentuximab CHOP CHOIP, brentuximab plus CHP, or anything differently you would want to do? So I'll begin with Dr. Pankaj, because you seem to have some experience with cyclosporin, and we do use cyclosporin in elderly who are not really fit for conventional systemic therapy. So I just wanted to start with you that if you have all the choices available, what would you pick up?
So unless the patient is very frail, then we still prefer to use CHOP therapy, or maybe you have brought up the option of bendamustine also. So bendamustine actually also is a good drug for T-cell lymphomas. Cyclosporine mostly we have used in a relapse setting, and definitely patients respond very well to cyclosporine therapy. You start with 3 mg per kg and go up to 5 mg per kg. The only problem is that these patients will respond for 6 to 9 months kind of a therapy with cyclosporine. It is not that I don't remember any patient who has gone on for more than 2 years or 3 years with cyclosporine. So generally, you in the relapse setting, when you don't have the options, and if they respond, they will respond very well. In the first month only, you will see the response with cyclosporine. Their hemoglobin will go up, their symptoms will subside, and even the lymph nodes actually they will go away. So they would respond very well in the first month or so, but the responses are not very long lasting. That's what I would say.
Sure. Dr. Biswas, anything different? Then I'll come to Rajiv.
No, Manju, so I don't have much experience on that.
So I would like to ask, sir, Pankaj sir, using cyclosporine along with CHOP, are you giving it as a single agent, or you start with along with CHOP and then stop CHOP and then continue cyclosporine? What has been your practice?
No, so our practice is not to use cyclosporine with CHOP therapy. I'm talking of a relapse setting. So in the relapse setting, cyclosporine alone, single agent, as I said before, 3 mg per kg to start with and go up to 5 mg per kg as tolerable. And within first month, you will know whether the patient is responding to this therapy or not. But the patients of AITL specifically who have autoimmune manifestations, as I said, ANA positivity or polyclonal hypergammaglobulinemia or even monoclonal, they generally respond very well to cyclosporine.
Sure.
So, sir, in the second line, when the relapse setting, then you start up with cyclosporine directly rather than going in for a salvage regime, sir, or you try to bring it into control and then shift over to cyclosporine, because we know we are expecting that when there is a relapse, there's a huge amount of disease burden. And so will cyclosporine be strong enough to just curtail that, or you want to use like a Gemox or something like a GDP, bring it down? And what's your thought?
No. So you would see all the large lymph nodes just melting away with cyclosporine. This is so fantastic to see actually.
Okay.
If the patient respond, they would respond very well. So obviously once there is a relapse, you need to check it by doing a repeat lymph node biopsy, because many times in Indian patients you will have some tuberculosis, sarcoidosis, or many other things. So you need to document the relapse and then start on cyclosporine. There is no need for a salvage therapy.
Nice. Thank you.
Just to follow up on Dr. Pankaj's observations, to me, in T-cell lymphomas, there are two entities that actually respond to cyclosporine. The first entity which responds profoundly is a panniculitis-like T-cell lymphoma, which responds exceedingly well, almost immediately with cyclosporine. And the other one is angioimmunoblastic T-cell lymphoma. But there is really no data to say where you're going to. In fact, there's no robust data also for cyclosporine in AITL. But having said that, you try to position it in situations like in the setting of relapse. But always the first line therapy in AITL would always be approaching it with chemotherapy, either with a gemcitabine based regimen or with, as we would for a peripheral T-cell lymphoma. And generally, they respond better when the volume of disease is much lower.
So this precisely, sir, in the sense that what would be, how would you choose? The next question is cyclosporine sounds fantastic. We have never used it as a single agent in the past. So how would you choose your patients for cyclosporine?
No,
is there some?
I don't think so, and except for the fact that it is an angioimmunoblastic T-cell lymphoma.
So, I mean, what we do many times with cyclosporine, I'm not sure whether, it's exactly what Dr. Pankaj mentioned, but, anyone who's frail, where we know that for frontline, what we are talking is where we know that giving CHOP or CHOEP, so typically these are in their late 60s or early 70s individuals, where we know that CHOP, CHOEP, both are going to be difficult. And they have significant amount of, autoimmune manifestations, relatively small size lymph nodes all over the body. These are the patients, they have done pretty well with cyclosporine. In fact, for some of these patients, we have used cyclosporine as upfront, but for others who are in that age group, because we know that for most regimens, if you're not consolidating with transplant, this disease comes back within few months. So we've used cyclosporin as maintenance too. I mean, these are all n is equal to 1 or n is equal to 2. So I can't say that, cyclosporin is truly effective. But at the same time, we have seen that these patients have maintained their, responses for a long period of time. So this is, don't quote us on this, totally not really an evidence-based medicine with the numbers what we have. But, what I feel that this drug does have some role. And especially where you cannot offer any intensive chemotherapy and transplant, and you're going to have practically the option of palliation, given that you don't have access to many of these novel agents. And those are the setups where one can use this. And bendamustine is another drug which, for this particular group, which is otherwise not very fit, can be considered if you're not really looking at anything beyond good symptom control and some reasonable disease control.
Manju, I would just rephrase, it's not that any patient of AITL who comes with a relapse, you just start with an cyclosporin. You discuss the option of salvage therapy as well as cyclosporin. And if it is, it is the patient's choice. So, and the patient, as Dr. Manju said, is frail and not very well fit to receive chemotherapy, only then you would start on cyclosporin. It is not, cyclosporin is not a second line agent for all patients. It's only for a select group of patients.
Yeah. And
so how do you choose, sir? So how do you choose? That's exactly, sir. Because I'd be very tempted to start off on Gemox or something very simple, then curtail the disease, and then, like Dr. Manju mentioned, then put the patient on cyclosporin. It seems more thing to me, sensible to me.
I would just say that if you feel that you cannot give Gemox to the salvage therapy, give cyclosporin.
Okay, yeah, absolutely. I would agree with what Dr. Pankaj said, that if your patients, you don't feel that they will even tolerate Gemox. And I must say that Gemox has not done wonders for AITL, meaning you feel good for first 2 cycles, 3 cycles. At the end of 4th cycle, the disease is again started showing its recurrence. So anyone where you feel any kind of salvage chemotherapy is not going to be usable. At the same time, they do not have really aggressive manifestation, meaning bulky nodes, massive splenomegaly, and all those. You can definitely use cyclosporin, and do try in this subgroup next time when you see the patient and tell us what has happened. Maybe we can all collate the data and look at what cyclosporin does in our patients, overall for this subset. So I guess we are running out of time. We probably have crossed 5 minutes. I don't know, Sachin.
Yes, ma'am. We have crossed.
Okay, so I'll just sum up, with 2 things. There is a lot of hope regarding a lot of novel agents. We have some successes with oral azacitidine as phase 2 trial. We need to look at, how it does in phase 3. The romidepsin failed in the phase 3 trial, so we are back to square one as far as PTCLs are concerned with in terms of romidepsin. Probably as single agent in relapse setting, yes, but not for the upfront patient. And for transplant, I just want to point this fact that there is, as Hari said, there's no randomized trial. This is the only largest prospective Nordic data which we have. Those who got CR or PR, they did better if you consolidated them with transplant. So anyone, where we see that they're in high risk category, meaning either in terms of PIT or in terms of IPI or T-cell score, if they're otherwise fit, our suggestion would be to offer them transplant based on this data. You can avoid the DUS22s and the ALK positive ALCL. They won't come in this category, but I guess we know that we don't have many salvage options, so that can be considered, especially if they have not received brentuximab upfront. Even though with brentuximab, those who underwent transplant, there's a suggestion that they do well with transplant as opposed to not having transplant, but no randomized trial here. So with that, I'll end, and I'll really, I'm really thankful to Puneet and Dr. Pankaj and all the other panelists for being here on Sunday. I know it's almost lunchtime. Thank you so much. It was wonderful.
Thank you.
Thank you. Thank you.
Can I take 1 minute? Can I take 1 minute? Now that I see all the seniors on one stage, I'm very tempted to please help me out solve one clinical scenario. So there is one 61-year-old gentleman. He is a known case of PTCL. He had presented almost 5 years back and had stage 3 PTCL not involving the marrow. He received CHOP, BAR, CHOEP, underwent an autologous transplant. And 5 years down the line, 5.5 years, he comes back with a new groin swelling. And now again, there is a isolated relapse in the groin with the lymph node. Now, my question is, do we redo the CHOEP? Do we offer salvage? Can we offer a second transplant? So I was tempted to ask this.
I'll start with the senior most people. And I'm really not sure between Dr. Pankaj and Hari who takes the...
Yeah. Hari will take up the thing.
So we should not speak simultaneously, Pankaj. Yeah. So see, there's nothing that but if this patient were to come, our general note that lymphoma as a systemic disease will skew me towards offering chemotherapy to this patient because it is 5 years since his primary diagnosis. And I would like to borrow a page from the early stage lymphoma protocols, because technically 5 years is a good time for a PTCL. Probably give him something which is not too intensive, like a gemcitabine based regimen over here. And then probably, if it is a large enough node, consider involved field radiotherapy to that area.
About second autologous transplant, Pankaj sir.
No, I agree with what Dr. Hari. The first thing is obviously to recheck by doing a biopsy, whether it is the same disease which was there 5 years ago, and then giving chemotherapy, and depending upon the situation, either IFRT or a repeat auto, whatever. If the patient you feel is fit, and you can take up the patient for transplant, definitely, because first time the transplant has really helped this patient for 5 years. So maybe that. Otherwise, if not fit, give IFRT after 3 to 4 cycles.
Great.
I'll only
Thank
add
you.
one thing, Puneet, here. PTCLs typically relapse very early. Even if they have to relapse, they relapse within first few years, and typically within 2 years, all the relapses would use. So as Dr. Pankaj said, I would really be keen to look at what the histology is, and whether it's more like those follicular helper T cells which can behave indolently. And you can probably then avoid, doing a transplant. Regarding chemotherapy regimen, I'm not sure whether you want to repeat CHOP or CHOEP. You've already given 6 cycles earlier, so you wouldn't want to, expose more anthracycline here. So
I started GDP. In fact, the patient had taken, I'm being honest, the patient had taken the first cycle and then came to me for an opinion.
Sure,
so
sure.
I was like,
so I would just, probably give GDP or maybe anything which is etoposide based otherwise. So depending on how the renal functions are and how the overall performance status is, any etoposide based regimen, and then, just give RT, especially if it is more like indolent. And transplant in this setting, according to me, I'm a non-transplanter, disclaimer first. So according to me, may not be really, very helpful. Given that the disease has remained well for 5 years time period. So this is all from my side.
Yeah, no, very valid. Thank you, everyone. I think it's been a great discussion and lots of learning for all of us.
Thank you.
Thank you.
Thank you.
Dr. Pankaj, we owe you a lunch party. For this. Yeah, thank you.
Please do call me at that time.
You're mute, yeah.
Quite a while.
I said at least a breakfast for me.
Yeah. And Dr. Biswas. Thank you, Dr. Ramesh Nemagala sir.
Yeah.
We'll
It is
definitely
nice that we
also
started
part of that
last
lunch
weekend.
party.
Last weekend we started with the rare tumors, and I think we're really closing with the real rare tumors. And obviously, some of them do well. So we have to keep doing it. That's nice. Thank you.
Thank you. Thank you.